Our job is to translate nutritional care science into policy. And we do this in different ways. And we do it because disease-related malnutrition is very prevalent. It is much more prevalent than people realize. And nutrition plays a key role in the acute and chronic diseases, many of them. And it's also shown that this is an extremely cost-effective way to manage healthcare. But nutrition is a forgotten care element very often. So we felt that nutrition needs a seat at the EU health policy table. And the way that we approach this is to work both at the European level and at the national regional level, because this is how EU works. It is all the different countries that feed into the EU, and then EU makes decisions and directions, and it goes out to all the countries. And it's a very interesting collaboration that goes back and forth, and it is understanding what is happening. And it's about gathering enough strength to actually be heard at the EU level and then make it move to the nutritional level. So we work with EU members and partner and have followed their projects, their EU projects, such as the Beating Cancer Plan and the Safe Heart Plan. And of course, we run this EU4Nutrition live things that is ongoing right now. We're working closely with the WHO, as you will hear a lot about during this session or during the conference. And we're present online by sharing practices between the different countries, so that if somebody comes up with a brilliant idea on how to move something and how to get the ears of decision makers or something practical that is worthy of spreading, then you can find a lot of these good practices online, actually. And then, of course, we have the ONCA conference, like this one. And coming up in the fall, we work closely with ESPEN for the Malnutrition Awareness Week. And we also run policy seminars, as we're doing here today. At the European level, it is working with the European Commission that proposes legislation. And then, of course, you need to have people in the Parliament that are keen to drive this and to vote for suggestions in our direction, and also at the Council of the European Union. So it's about working at 3 different levels, which is important to actually make things happen in the end. The Malnutrition Awareness Week is really something local, and it's run in slightly different ways in different countries. I know France, for example, has a huge program with many, many activities, and other countries may have a very specific thing that is ongoing to drive an issue that is of particular importance in that country. And we try to support that in the best way we can, in different ways. And it is my pleasure to also introduce to you that we have a new Patient and Nutrition Impact Group that was initiated this morning. And the idea is to produce a sustainable approach to patient advocacy so that they have a stronger voice within our organization, and that we can together make a stronger case wherever we go with these policymakers, because the patient voice can make all the difference. And I know they have some brilliant ideas on how to do this, I heard this morning. And I think it's extremely important that we as professional clinicians really make sure that when it comes to policy making and driving these kind of things, that we make sure we have the patients with us and listen to them, because they really know what is needed. This is another very big opportunity to drive our cause at many levels in Europe. It is the ICD-11 coding of diagnostics that is coming out and is being introduced in many countries next year, ICD-11. And so this is really putting malnutrition in adults, has been accepted as a specific diagnosis, which will have major impact financially for sure, because then all of a sudden that additional diagnosis will render more payment to the care provider. And this is something that we need to drive in different countries to make sure that this is also happening at a good level. And that will obviously lift the sort of the focus on malnutrition to a much higher level and become more part of daily work in many, many hospitals. So that's a big plan that we are going to move, and we feel that our organization can play an important role in driving this, as we are a multi-stakeholder organization. So we have been already receiving some support from ESPEN to form a task force to start planning this project that will be running for several years in the future. We will be hearing more about that in a special session by the people who have also been driving this and making it actually happen, which is a story in itself that is very interesting. So, moving on to the program today, we will learn about top-level French good practices and experiences, and they are plentiful, I must say. You've done a fantastic job here. It will be about policy shaping in the European Union, the potential of EU policies, and also the importance of multi-stakeholder approach with patients at the center. So we try to really get these guys on board and help us see what is really needing. And it's about providing access to optimal nutritional care for all in need. So again, I welcome you all to this couple of days. We're going to have a lot of interesting discussions. We're going to listen to some fantastic speakers who have been driving change in an important way. So again, very welcome.
I'm Agathe Reynaud-Simon. I am the president of the French campaign group or French initiative of fight against undernutrition. This started actually in the ONCA campaign, of course, that the French attended since 2015. So this gave us ideas to work in France. Do I take this? First of all, a very warm welcome to you all. Thank you for coming here. We are very happy to host you in this wonderful place. So when I was preparing these slides, I thought back in the first time we welcomed the ONCA group. It was in 2019. So you see some photographs from that time. At the right, you see Eric and I. And we also had the president of the National Food Council at this time. And also at the right of the photograph, Jérôme Gage, who is a member of the French National Assembly and who did a lot for us to start building our campaign for malnutrition in France. So while we are here, I give him a very warm thank you for all he did for the initiative. And also what was important at that time is that we had the Dr. Michel Chauliac, who implemented the first French National Nutrition and Health Program for the Ministry of Health. So he came to the ONCA meeting, and it was really nice to have him, and he got very enthusiastic about our projects, and also he helped us to begin all this. So how did we start thinking about our initiative? Well, it was Eric's idea to begin with basic numbers. And we wanted to estimate how many malnourished people there were in France. And so we did it with the numbers we had, which was 30% of hospitalized adults are malnourished. And we could have access to the data of the number of adults hospitalized each year and the number of times they were actually hospitalized per year. So with this, we calculated approximately 2 million people. And this number got the attention of the public stakeholders. And we could begin to talk about malnutrition. So it was a big step to go with these numbers, which were then cited in the one of the national health programs written by the Ministry of Health, so this was good. But the thing is, it's okay to estimate in one way, but after that, much later, we tried to have real data to see if the numbers were good. So we could work with the French National Health Insurance, and the first thing we asked them is how many people do get an ONS and get reimbursed for it. This is why they have the data. So you see that in 2022, well, there were 1.3 million policyholders who were reimbursed for at least one ONS in this year. So that's nice to have for numbers. You see there are also children that get ONS, but clearly this increases with age. The interesting thing is the median age is 75, so half the population that receive ONS, so then they have been diagnosed with malnutrition, are also younger. It's not only older people, and this is a message we really have to repeat very much to politics, because they assume it's only older people who get malnourished. So these data were interesting to present also. In this slide, though, the people that are 65 years or more represent more than 1 million persons. Also, the French National Health Insurance could give us the number of hospitalized patients that were diagnosed as malnourished and coded in the French coding system. So 9%, we know this is not the right, of course, the right number. So in France, we have the same problem as everywhere else. It means that malnourished is poorly recognized and then poorly diagnosed and poorly taken care of. And you see also that there are very small children to very old people. Of course, it increases with age, that are malnourished. So we have a lot of work to do still to increase malnutrition awareness in the community and in the hospitals. So we started the Malnutrition Awareness Weeks in 2020 in France. We were financed, we got funds from the government and also other public structures. I've put here all our partners for 2025. And you see that we began pretty small with 368 actions. We counted them exactly. And then the things got on quite well. And you see that in 2025, there were 20,000 actions done in France for malnutrition awareness with all the data we collect on our site. And almost half the actions are put on the site with dietitians, of course, but they're also in the restaurant, the food kitchens in the nursing homes that do many actions. And what we are trying to develop more is the action done by the professionals in the community. In the community, we have mostly physical activity sessions done at the moment of the Malnutrition Awareness Weeks, which is a great success with an association done with Ciel Bleu. So this is where we are now. We are preparing, of course, 2026. So now, let's fight together. Thank you.
Bonjour à toutes et à tous. Je suis très heureux de vous accueillir aujourd'hui à Paris au nom du ministère de la Santé pour ce colloque international consacré à un enjeu majeur de santé publique, la nutrition. Je tiens à remercier chaleureusement les organisateurs pour leur invitation, le collectif de lutte contre la dénutrition, la Société francophone de nutrition clinique et métabolisme, et enfin les équipes de l'ONCA. Je regrette de ne pouvoir être présent parmi vous aujourd'hui pour des problèmes d'agenda, mais il me paraissait essentiel de vous adresser quelques mots à l'ouverture de ces travaux. Je souhaite avant tout saluer votre mobilisation et votre présence qui témoignent de votre volonté d'agir communément sur la nutrition comme levier essentiel de santé, de prévention et de qualité de vie à l'échelle européenne. Ce sommet met en lumière une problématique sanitaire et sociale majeure, celle d'une alimentation saine, adaptée aux besoins nutritionnels de chacun tout au long de la vie et durable. Prévenir la malnutrition, tant le surpoids et l'obésité que la dénutrition et les nombreuses pathologies associées, demeure un enjeu majeur dans nos sociétés contemporaines de l'abondance, confrontées au marketing alimentaire et au développement de l'alimentation ultra transformée, à la sédentarisation croissante des modes de vie et enfin au vieillissement démographique. En France, vous le savez, le Programme national nutrition santé, le PNNS, porte depuis plus de 20 ans la politique de prévention nutritionnelle du gouvernement afin d'améliorer la santé dans la population à travers l'alimentation, l'activité physique et la réduction de la sédentarité. Ce 5e PNNS a été publié très récemment lors du sommet One Health organisé en France en avril dernier afin de renforcer notre action sur le sujet à l'horizon 2030 grâce à la mobilisation de plusieurs leviers pour faire évoluer l'environnement alimentaire et physique, pour le rendre plus favorable et encourager les comportements nutritionnels sains et durables. Ce programme a permis plusieurs avancées au fil des ans pour améliorer la santé nutritionnelle de la population, tant sur la prévention de l'obésité que celle de la nutrition. Je pense notamment au déploiement du Nutri-Score, qui permet d'aider chacun à choisir des produits de meilleure qualité nutritionnelle, mais également d'inciter les industriels à améliorer la composition de leurs produits. Je pense également à l'accord collectif conclu avec l'ensemble des professionnels de la boulangerie, qui a permis de réduire de 20% la teneur en sel dans le pain en 2025 par rapport à 2015. Et enfin, bien sûr, à la création, à l'initiative du PNNS 4, d'une semaine de la dénutrition mise en place chaque année en France depuis 2020. Elle est animée et coordonnée par le collectif de lutte contre la dénutrition. Elle vise à sensibiliser et mobiliser les professionnels et le public sur cette pathologie encore insuffisamment dépistée et connue, et à lutter contre les idées reçues. Nous constatons avec satisfaction une mobilisation croissante d'année en année autour de cet enjeu. Les résultats de l'édition 2025 témoignent de cette dynamique. Plus de 3000 organisations se sont mobilisées pour cette semaine de la dénutrition. Près de 20 000 actions ont été menées sur le territoire qui ont permis de toucher près d'1 million de personnes. Ces avancées ne masquent pas les défis importants qui demeurent pour la France. En effet, aujourd'hui, un Français sur deux est en surpoids ou en obésité. La dénutrition touche environ 2 millions de personnes et on estime qu'un décès prématuré sur 5 serait lié à l'alimentation et un décès sur 10 à la sédentarité. C'est pourquoi le PNNS 5 réaffirme des priorités fortes et porte des mesures concrètes telles que réduire progressivement la teneur en sucre des produits fréquemment consommés par les enfants, encadrer le marketing alimentaire, par exemple protéger les jeunes des publicités pour des produits non sains et dans les fast-foods, inciter la grande distribution à retirer les confiseries des sorties de caisse en supermarché, poursuivre le déploiement du Nutri-Score, améliorer la qualité nutritionnelle des repas dans les établissements de la petite enfance, encore renforcer la prévention et le dépistage de la nutrition, faire du surpoids et de l'obésité chez l'enfant une grande cause nationale d'ici 2030, promouvoir l'activité physique et sportive et réduire la sédentarité. Enfin, bien évidemment, je ne peux pas tous citer les mesures comprises dans ce PNNS. Les enjeux nutritionnels que nous cherchons à comprendre et à résoudre sont communs à l'ensemble des pays européens. Le vieillissement démographique, l'augmentation des maladies chroniques, l'explosion de l'obésité, la précarité alimentaire et la perte d'autonomie. C'est pourquoi des espaces comme celui fourni par ce sommet sont clés. Ils nous permettent de partager nos expériences, nos bonnes pratiques, nos outils et nos innovations. Cette coopération européenne est indispensable pour faire progresser collectivement nos politiques publiques et améliorer durablement la santé des populations. Je forme donc le vœu que ces journées donnent lieu à des échanges riches, utiles et porteurs d'initiatives nouvelles. Je vous souhaite un excellent colloque et des réflexions utiles, pertinentes et un très bon séjour à Paris. Je vous remercie.
So I think it's extremely important that we hear what the focus of the politicians are. There was some malnutrition in there, but there was also a lot of other things. And we got to know where they are, because if you're going to lead somebody, you have to start by finding them where they are. So, okay. Well, now it's my pleasure to introduce Christelle Guillet. She's the Vice President of Société Française Nutrition, Clinique et Metabolisme.
Thank you, Ole. Good morning, everyone. First, I would like to apologize Professor Didier Quillot, who is the president of the SFNCM, who couldn't, unfortunately, come today. So it is a great honor and a pleasure to welcome you today on behalf of our society and as a member of the French ONCA team. I would like to warmly thank the European Nutrition for Health Alliance and all the partners involved in the ONCA campaign. The SFNCM participated to this year's conference, and it was really important for us because for the people who don't know the society, I prepared some slides. We are a multidisciplinary scientific society bringing together physicians, dietitians, pharmacists, nurses, researchers, and allied health. And we are, as you can see on the slide, organized in different committees. And our goal is to improve the prevention, the diagnosis, and the management of malnutrition through different missions. Okay. First, we are organizing scientific congress, webinars, publications, and also we are involved in collaborative networks. We have two main congress, a small one, little small, the Journée de Printemps of clinical nutrition. This year, these days will be held in Limoges at the end of June, and we will talk about notably nutrition and neurodegenerative diseases. And we also participate and organizing another congress, the French National Congress of Nutrition, which is the biggest congress in nutrition in France. We have more than 2,500 participants, and this Congress is organized with the French Nutrition Society. And this year it will be held in Lille in November. As I say, we also have some webinar. Our importance is to provide and to disseminate scientific and clinical knowledges. The SFNCM also actively supports the implementation of best practices for nutritional screening, assessment, and management. So for that, we develop regularly clinical guidelines, practical recommendations, educational programs, and training tools designed to help healthcare professionals to identify malnutrition early and provide effective evidence-based interventions. Third, and perhaps the most importantly, the SFNCM serves as a reference society and center of expertise in the field of clinical nutrition and metabolism. So we work closely with different scientific societies, and we are working more and more with the Collectif. And I take the advantage to thank them warmly for the participation for these conferences. So all of the objectives of the society are fully aligned with the vision of ONCA. Together we share the conviction that nutritional care is not an optional component of healthcare, but the fundamental right for every patient. I would like to acknowledge the commitment of all members of the French ONCA team, including Le Collectif, the patients' associations, the scientific societies, healthcare institutions, and representatives of the Ministry of Health, whose engagement demonstrates that improving nutritional care is a shared responsibility. I thank you very much for your attention, and I wish you an excellent and inspiring conference.
Thank you, Christelle, and also thank you for working with us on this ONCA meeting. So now I will ask Cécile Cotus to come. I already spoke. So you can come here if you like. So Cécile Cotis is a dietitian. She represents the French Association of Dietitians and Nutritionists, which is AFDN.
Good morning, everyone. So I am Cécile Cotus, dietitian nutritionist, and I'm representing the AFDN today, Association of French Dietitian Nutritionists. I have some. Thank you. Okay. Our association, which is about 70 years old, has approximately 2,700 members with about 70 volunteers. We represent French dietitians who works in the city, in primary health care team, in hospitals, nursing home, and catering, schools and firms catering. We produce newsletter, practice guidelines, a peer-reviewed journal, professional development days. This year, these days will take place at Lille, too, in October, and there are a lot of conferences and experts who participate to train our dietitian. We are a member of EFAD, European Association of Dietitians, and a lot of national French organizations. The dietitians are very involved in managing malnutrition, and the association releases every year the Malnutrition Awareness Week. We are trained and available throughout the territory to participate in keeping elderly or fragile patients at home for as long as possible. So with our association, we can unite and represent the dietitian. I can say dietitian, just dietitian, please. It's easier for me. So we represent the dietitian here in every congress like SFNCM, and every time the ministry call us. We are positioning the dietitian as a key player in the healthcare system, and we are supporting the evolution of professional practices. So we are ready. Thank you for your attention.
Thank you very much. So, last but not least, we are very happy that Jean-Pierre Thierry has accepted to come here to represent the patients groups. Jean-Pierre Thierry is a medical advisor at France Santé, president of the Patient Outcome Consortium, the National Collectif of Patient and Health System User Associations in France. So it's the associations of all associations. Thank you.
Yeah. I mean, it's a real opportunity for me to be here because I have the chance to listen to all the efforts you make to push forward in the agenda, which should be a top priority. And as you said, it's not only neglected, I mean, in some countries, but it's efficiently taken into consideration, and it's highly strategic. And I'll try from France Asso Santé, as you said, is an umbrella organization. So we have more than 95 patient, citizen, and even consumer organization. If they are certified by the Ministry of Health, they could join our group. Our group is publicly funded by law and has to be considered for any policy decision in France. And so I just want to stress the fact that we could have a voice because we have no conflicts of interest. So also we are full member of the European Patient Forum, so we follow what the EPF is doing with you closely. And I would just stress the fact that looking at two dimensions in France, I will start with the nutrition at the old age. But at France Asso Santé at the moment, as Mr. Lepetier said, the DGS, as we say, which is one of the two directors of the Ministry of Health, well, they are more than that, but the main director of the Ministry of Health, we look at nutrition as a general systemic endeavor, trying to fight the progress of ultra-processed food at the population level, because we have an increase in metabolic syndrome in France and obesity. Also, it's a bit more controlled than anywhere else. Just to remind you, you will mention Safe Hearts. We have the lowest mortality rate in the world for cardiovascular, okay, with Japan, but it might change over time if ultra-processed food and could progress. Also, despite this very good result, we have very, very high social gradient that you might find in your field, which characterize France. So in France Asso Santé, so we are fighting hard to have the Nutri-Score mandatory in France. Almost passed, short of 3 votes at the National Assembly, but we'll try again. We have a lot of people following us. We know it's tense because we discover, thanks to the Lancet, the reality of what is called commercial determinants of health. Okay, so we have to fight for that. One of the fight also we have is to try to impose, with no success so far, a minimum price unit for alcohol, which is one of the best buy of WHO. Just to remind that 10% of the drinkers in any country drinks 50% of alcohol. It's a Pareto law. 20% drinks 80%. Okay, so and minimum price unit for alcohol has the same efficacy than the price for tobacco, but only 3 countries in the world are using it today. So. Also, we look closely at integrated care, the way to defragment the pathway for patients, you know, paying in bundle of care, for example, because as in some other country, we're too dependent on DRGs for payment in hospital, you know, payment has no incentive to shorten the length of stay somewhere, like in other countries. And also in the outpatient settings, we have a lot of codes. Codes are important, I don't say that. But then, we push to move to another kind of economical model that will defragment the healthcare system, and including the people who will be involved in nutrition, which is not the case today, and we know that. The other dimension is about enhanced recovery after surgery. That only knows well. I know, I've made my study. I know this. Okay, but you know, what is very striking in this example is that you have increase in efficacy and you have a decrease in cost. So it's called dominant in medical economics. And it's not taking up anywhere. So I say, why is that? And to illustrate my profound thinking is that I have to go back to commercial determinants of health, especially if you work at the European level. You have guidelines, you have lobbies, you have people working to try to make the agenda at the top of the list, which will impact the willingness to pay of any healthcare systems. And in that respect, if you look at nutrition, most of all, it's organizational. There's no product to sell, except in the good indication validated, okay? We call that ONS, which might be underfunded, I don't know. But if I look, you know, if I look at the systemic issues, we have a sustainability issue, near term. So we will have very strong choices to make to allocate resources the most efficient way. And the way it is going, the most powerful will win. And the most powerful are the commercial players. And just to finish with that, thanks to France Santé, I'm in a commission that might compare the increasing of quality of life due to any intervention, although it's limited to the drug. Okay? But I regret that, because we have very good drugs. Change the prognostic of cancer, digestive cancer, for example. But you know, so we accept that it's 30,000 euros per year adjusted to quality of life. But some of them are more expensive than that. And if you look at the prescription patterns, it's taken very fast in any healthcare system, especially in France. We are a very high prescriber of new drugs, contrary to what is written somewhere. And in the meantime, if you look at nutrition, you know, or ERAS, it's not taking up. So what's that? So we have misalignment of incentives, we have misallocation of resources. And I just will to finish with that. That's why your work is so important. It could change that at the European level, but you have to work at the national level with people free of conflicts of interest. And the most important term could be public health policy. Thank you.
Well, thank you so much for this talk. So now we're going to go ahead, and I will ask, so who do we come?
Now, okay, yes, we had, unfortunately, Victor Negresco from the European Parliament is stuck on an airplane. It was delayed, so he is not able to join us. And that means that we were shifting around a little bit in the sessions around lunchtime. And fortunately, we have two good friends sitting in the back who were ready to step in earlier. Stanislav Klek and Grigoris Rivas will also join. And then, so we will actually start this session with Mailis Selenius. And she's coming up here, and I think we should give her the pointer. Yeah. So Mailis is from Karolinska Institutet in Stockholm, Sweden, and she is our go-to person for the whole country when it comes to understanding how we should live a healthy life. And she knows everything about all the data that is out there, and it's a true pleasure to have her here with us to present on the scientific evidence for EU cardiovascular health and nutrition care strategy. And we are now moving into that would be an excellent start of our session, which is going to be discussing integrating nutritional care into the European health systems. Yeah. So, Mailis, pleasure.
Thank you very much.
Pleasure to have you here.
Very kind introduction. We heard about sedentary behavior, and can I please ask you to make 10 squats while I'm waiting for my slides? Sure. Please. Up 1, 2, my slides. Very nice. Okay. Good. They put that. So, thank you very much for the invitation and the very kind introduction. I'm a physician and a researcher. I'm a professor of cardiovascular prevention, and my area is nutrition and physical activity, and I work at Karolinska Institutet at Stockholm, Sweden. Well, and I have nothing to declare. I will shortly comment upon 3 things. The knowledge about nutrition and health is rapidly growing, but the public is exposed to conflicting messages. What is then evidence-based nutrition for us humans and also for the environment? And a reminder that I think we have to start early in life. Well, we are living in the middle of the digital revolution, and that's why I ask you to take the opportunity to take a short break for movement. There are new possibilities in the digital revolution, but also new difficulties. And this is the front page of Science, illustrating a study showing that lies or fake news spread 6 times faster and more effective than truth. And I've been in this area for 40 years almost, and I think today it's in fact more difficult to spread the knowledge about a healthy nutrition. What is then evidence-based nutrition? Well, the answer is to be found in the regularly updated recommendations and guidelines, international ones and national ones. And an evidence-based optimal eating pattern could be described in, for example, this pyramid. And look at the broad basis. And by the way, it's standing on everyday physical activity. The broad basis is full of vegetables, berries, fruit, 500 grams a day approximately, a handful of legumes, a handful of nuts, whole grain, and vegetable oils to be used as the main fat. Seafood, at least 3 times a week, some poultry, eggs, dairy products, and just small amounts of processed meat and red meat, 350 grams per week, prepared meat, and small amounts of sugar and salt. How do we know? Well, observational studies are in fact very consistent. And for example, this extensive overview or meta-analysis of over 100 studies with over 3 million participants clearly show that if you have this pyramid in your mind, this eating pattern is associated with decreased risk not only of cardiovascular disease, the new heart plan, also common cancers, type 2 diabetes, neurodegenerative disorders like Alzheimer's disease, Parkinson's disease, risk of dying prematurely. And also today we know that survivors after myocardial infarction or cancer, well, a healthy dietary pattern is associated with a better prognosis. We heard about also planetary health, and it's exactly the same dietary pattern. And last year, the Eat Lancet Diet Sustainable Food Systems was updated, and you see it's illustrated here in a plate, but it's, well, actually the same as the pyramid. And in one of the largest prospective observational studies, that's the studies from the United States, Nurses' Health Studies and the health professionals, they used this planetary health diet index and studied how it was associated to health during 34 years. And you see from this slide, there is a very strong dose-response relationship between the adherence to a sustainable and healthy eating pattern. So it could be expressed like every bite counts. And in this study, as the other 100 I shortly commented upon, there was a strong association between healthy dietary pattern and all-cause mortality, non-trauma causes, cardiovascular disease, cancer, respiratory disease, neurodegenerative diseases, and infectious diseases. So it's good for health in general. And it was also clear from this study and many, many others that this protective effect is applied to all of us, independent of age, sex, ethnicity, socioeconomic factors, smoking, alcohol intake, physical activity, body weight. In this study, they also tried to study how much do different kinds of food matters. We have to remember that the lists are long. But the top 3 positive effects were the intake of nuts, whole grain, and unsaturated fat, for example, olive oil. And the top 3 negative was saturated fat, and we have to remember that butter is very high in saturated fat, palmitic acid, added sugar, and processed or red meat. Is this new? No, it's not. There is a great focus on sugar taxes and so on, and that's fine and good. But we also have to remember that fats are very bioactive, and this is another analysis from the same studies that I commented upon, where they followed over 200,000 men and women for 33 years, showing that each 10-gram increase in butter, if I go back, was associated with a 7% increased risk of dying during these 33 years. But each 10-gram increase in plant-based oils, vegetable oils, decreased the risk with 13%. And replacing 10 gram of butter with 10 gram of olive oil reduced the risk of dying prematurely with almost 20%. It's so little. It's a package from the breakfast at the hotel room, or 2 teaspoons of olive oil. Okay, we are in France. 30 years ago, this landmark, it's a cornerstone in preventive cardiology, was published. Imagine 600 men and women. They are not young. They suffered from their first myocardial infarction, but they are survivors. And they were randomized to 2 groups. One group receiving support to follow an even more healthy Mediterranean diet, and the control group did not receive this kind of dietary advice. The study was planned to go on for 5 years, but it was stopped for ethical reasons after 27 months. And the ethical reasons, this is a pointer. No. You see, in the control group, 17 suffered from a new myocardial infarction during 27 months, and 16 died. This means that after 27 months, the risk of suffering from another myocardial infarction and dying from it was reduced with 70–80%. This is the power of healthy food. Let's move on. And this is another cornerstone from our neighbor country, Spain. 7,447 Spanish men and women, 55 to 80. Half of them have type 2 diabetes, and the rest have high blood pressure, overweight, abdominal obesity, well, quite common people. And now they were randomized to 3 groups. One group receiving support to eat a healthy Mediterranean diet, and they were also given 1 liter of extra virgin olive oil per week for free, and they were asked to take an additional 3 tablespoons extra per day. Group 2 received the same kind of advice, but they were given for free walnuts, hazelnuts, and almonds, and they were asked to take an additional handful, 30 grams extra per day, and the control group did not receive this advice. This study was in fact also stopped in advance, because after approximately 5 years, every 3rd myocardial infarction or stroke was prevented. And that was the main objective to study. However, PREDIMED, they have published over 300 scientific reports showing that among the people that were free from type 2 diabetes at the beginning, type 2 diabetes incidence was reduced with 50%. The incidence of breast cancer was reduced 68% in the olive oil group in women. The risk of depression, cognitive decline, and so on was decreased. This study confirms the results from many, many observational studies. And we know so much more today about underlying mechanisms, but I won't go into that today. Well, the adherence to dietary guidelines in Sweden or in other countries in Europe is quite low. For example, in adults, as in children in Sweden, 80% have a too low intake of fruits and vegetables. 80% have a too high intake of saturated fats, 70% eat too little fiber, and 4 to 50% eat too much sugar. And it's almost the same in many, many other European countries. And for example, the consumption of butter is increasing in France and in Sweden and in Denmark. So this sad data, the low adherence to dietary guidelines, also means that there is a great potential, much health left to gain. So just a few slides left. These are estimations regarding the effects on lifespan of healthy eating on a European population. And if we start to eat healthy from the age of 20, it might be that life expectancy increase with some 10, 13 years. Start from age 60, 8, 9 years. Start from age 80, 3.5 years. Okay, so finally, we know today that disease processes, and that's true both for cardiovascular disease and also neurodegenerative disorders, starts early in life. And with new imaging techniques, for example, we can see early signs of atherosclerosis already in the fetus, if the pregnant woman, the mother, for example, have high blood lipids. And we know, for example, from very nice studies from Finland and the United States that unhealthy lifestyle is linked to atherosclerosis, different kinds of measures of intima media thickness in the aorta. Already in young people, habits are established very early in life. So, Mr. Chairman and dear audience, my message, and dear Chair, turn to the man, as always. Do not underestimate the power of healthy food. And there is much health and well-being left to gain. And promotion of healthy diet has to be evidence-based and start early. And I think this meeting and the wonderful program is really the proof that we now have turned into a time for more focus on implementation. Thank you very much.
Thank you very much.
Well, oops. Miley's, like I said, she is the go-to person for all of Sweden. So she is now going to head straight to the airport and go to give another talk in northern Sweden. So we're just happy to have her here for this presentation. Thank you.
We could now welcome Marco Greco, who is the president of the European Patients Forum, and we will talk about policy tools to tackle unmet nutritional care needs for patients. Thank you very much.
Thanks. Thank you. Thanks for the invitation. That was much appreciated, and thanks for this chance to speak to such an audience about this important subject. We will try to summarize, let's say, what are the issues and the challenges to be translated into policy in order to reach as much population as possible. The previous presentation was amazing, I have to say, but we need to find a way to make it practical and active for every patient. I think there was a very interesting reflection in it about the fact that we have all the guidelines, but very little of these guidelines actually get to the single citizen in Europe. And this is a pity because we are, I don't know for how long, but we are a wealthy and healthy population, and we need to keep pushing on this. And before starting a reflection, there is something weird about the subject we are discussing today, and it's the fact that I think everybody can agree on the fact that we need food. It is what it makes us going every day. It's essential for us. But apparently, there's no political willingness, or at least there is no overall willingness to get it done properly. We are lacking of educational programs where there are lots of information there, but they don't get to the citizens. And that is weird, because it's about our capacity of surviving, and not only surviving, but of living better. And so let's see together how we can maybe implement some of these policies together. Yep. So I think we need to start from one important message, and it is that nutrition is not only supportive care, but it is a core component of the treatment. Because there is an hidden burden of disease-related malnutrition, for example, no? Because we are used to focus on older adults, sometimes on cancer patients, sometimes on the chronic disease population, and we summarize it in hospitalized and long-term care patients, but then it stops here. Very often we do not make the further step. There are relevant nutritional care gap, particularly, of course, I'm representing patients, so I will focus a bit on the patient perspective on it, and so I'm also specialized, let's say, in chronically ill patients. So please forgive me if I will underestimate something on other areas, but we can see a late or absent malnutrition screening when it comes to the admission to the hospital. It's still not happening very often. It goes on with inpatient care, with the limited access to dietitians and specialists, with low nutrition literacy among professionals and patients very often. And we are keep on pushing as patients organization also for having more and more of these integrated care and discussion with different healthcare professionals. The healthcare systems, the way they are designed, are not really, let's say, friendly to this approach, but it's something that when it's there, it changes the life of patients. In the phase of discharge, there is very often poor continuity of care, or that is even more relevant, particularly in certain countries, inconsistent reimbursement policies, and that doesn't help. And in the post-discharge phase, we notice an inequitable access to oral and enteral nutrition. I have touched already the two main themes of my presentation. On the one hand, there is the awareness, because there is an evident lack of translation of the evidence base into policymakers' action. And that requires, that shows a need of reviewing the care pathways, but also the necessity of keep on pushing on research for building the case when it comes to develop then policies. The second point is probably the most relevant, and it is about equity and equitable access to therapies. Nutrition is part of this and shouldn't be underestimated. And at the moment we see that this is still happening. Even if everybody is getting theoretically the same care, the way this care is received in Europe is not the same. We need to find a way to fill these gaps, and we need to find it together. So we need to tackle these, because we have a ripple effect if we do not act. Because disease-related malnutrition is a very generic expression, but it takes with it a lot of stuff. It takes longer days in hospital, higher hospitalization cost, more readmissions, increased long-term care burden, productivity losses. On the other side, there is an increase of infections and complications, a reduced treatment tolerance, the delay in recovery, the increased mortality, and the reduced quality of life. and we have evidence, and they were also shown very well in the previous presentation, that an early nutritional intervention is associated with improved outcomes and lower cost. I think the data that hits me more from the previous presentation was the one about how a nutritional intervention can change embed the possibility of having a stroke, for example, or even how it affects the therapies when it comes to cancer therapies. Root causes of failure. There are systematic barriers that, for example, the fragmented care pathways, and it is something that it has to change from a political standpoint, because very often I do work with healthcare professionals, no? And you know better than me, you have your number of visits that you have to do per day, very few time that is less and less every year to dedicate to patients, and then the commitments of the other staff, a huge bureaucracy to face. And it's difficult to cooperate with different departments. For example, it's not facilitated by the system. That may lead to delayed interventions. There is, of course, the issue of limited reimbursement that is leading us to underutilization of nutritional therapies, for example. And when this is happening for budget reasons, it's terrible. Because it means that you have there the instrument that can change the life of these patients, but the patients cannot get it because of reimbursement barriers. There is, of course, a workforce shortage. That means that for the patient there is a reduced access to expertise. I don't think it's today the right day for mentioning the issues about the problems in healthcare, in the careers for health professionals and all the related issues, but it's there, it's part of the things that we need to support and to improve. Lack of standardized screening, the differences between different countries in Europe is huge, is dramatic, I would say. That may lead to missed diagnosis. A weak data collection for the same reason. That means limited policy evaluation. So it's a problem because we don't get enough data for promoting a policy action. And overall, there is still a low awareness because nutrition is seen as secondary care, and not as primary. And this is, I think, a problem we should start from. When it comes to policy, we need to think of it as an integrated policy ecosystem, so macro policies and micro policies. There are clinical actions that requires macro policy support. I have tried to summarize those in 6 main interventions. Of course, there is much more, but also we cannot stay here today, so at least talking about these. So I've tried to think about 6 intervention functions that can be seen as an integrated clinical pathway, transforming what at the moment are very often or too often isolated actions into a robust nutritional architecture. That means mandatory screening, reimbursement reform, multidisciplinary care, workforce education, digital health systems, and public health prevention. So the frontline interventions that I highlighted before as tool 1 and 3 are the mandatory nutrition screening and the multidisciplinary care models. In this case, make a screening a standard of care at hospital admissions requires standardized validated tools integrated into electronic health records, and of course it will require, or it's requiring a periodic reassessment. And all of this is a cost for the system. That is the first reaction we will have from policymaker will be, okay, but who's going to pay for that? Where we're going to find the resources for that? And as KPIs, we need to think about percentage of patients, measuring percentage of patients screened within 24 hours or rate of malnutrition diagnosis. In the workflow integration that will lead to multidisciplinary care models, that means integrated nutrition deeply into patients' care, embed dietitians into care teams, create dedicated nutrition support teams, coordinate across hospital, community, and home care, include nutrition in the discharge planning of the patients. The benefits may be faster interventions, better continuity, and improved adherence, and hopefully reduced admissions. We need also to, as I said, money is always an issue, to find a financial and structural way to enable these. So reimbursement and financing are for sure an essential tool here. We need to find a pathway for reimbursing clinical nutrition services or reimbursing better. Expand coverage for oral nutrition supplements, incentivize preventive care, introduced value-based payment models. This is happening for other class of drugs. I believe it can make sense also here. The anchor principle is that what gets reimbursed gets prioritized, and so we need maybe to leverage on that. These should drive a better adoption and validation system, and it leads us to another tool that is digital health and data system has been over the last year the next big things. Now we are already moved to another system with the AI, but we need to find integration nutrition alerts, telenutrition and remote patients monitoring, AI-assisted risk identification and national registries that are still missing in many European countries. The system needs, since the beginning, data interoperability, privacy, robust privacy policy, standardized outcomes measures. Otherwise, we won't be able to sustain the system later on. Also, we need to upstream the capacity building. That means, on the one hand, to support the training of the healthcare professional, physician, nurses, pharmacists, caregivers also, and community health workers, increasing training, developing continuous CPE, creating competency standards, and promote interdisciplinary collaboration. I'm eating a lot on these, but I've seen the results also on myself. I have a very strong personal experience to see the difference when I had the chance to be admitted in an hospital in which there was an interdisciplinary collaboration and in an hospital in which it wasn't there. It made a complete change in the therapies I was undergoing. We need to think about a long-term goal that is reduce disease-related malnutrition even before the hospitalization occurs. We need to work on public health and prevention. That means community nutrition programs maybe, or healthy aging initiatives, public awareness campaign and food security interventions, and chronic disease prevention program where they are possible. Public awareness campaigns are sometimes controversial, but they are essential. We need to reach the public. We have seen before how much easier it is for a fake news to spread rather than to science-based information to reach the patients. But that doesn't mean that we have to quit there. On the opposite, it means that we have to invest more. We need to reach as much public as possible and to deliver the message and to spread the message, the correct message. Of course, science is evolving. I was telling to a colleague this morning that while I was preparing this presentation, it came to my attention some TV spots of public campaigns that I've seen when I was in school. I'm Italian by origin. And some of them are still very actual. Some of them are now something completely unacceptable, no? Because over the last 40 years, we have completely changed the approach on certain things, no? I just want to mention one that was a clear invitation to use more sugar for getting more energy if you are a kid. now it's something that will be even more controversial. It will be, let's say, dramatically controversial, but it was there. I mean, we are learning by mistake. The imperative here, and I'm going towards the end of my presentation, is to maintain equity. Equity means equitable access to every citizens in Europe. We have 5, let's say, communities that I have identified, and for each one of them there is a policy bridge that we need to build. Thinking about older adults, we need, of course, affordable access to nutrition therapy, low-income population, even there, affordable access to nutrition therapy. Rural communities, there is the issue of geographic access to specialists. Patients with disability, we need a more dedicated, appropriate care. And ethnic minorities, but in general, I would say, with the disinvestment of culture, that will become more and a more wider problem, health literacy support. The data are there, the informations are there, but, and they are, the paradox is that we are living in a world in which it's so easy to find information. What is difficult is to understand the information. Policy scorecard, we need metrics. We need metrics if we want to translate these into policy, into something that will happen, and so pushing a policymaker to integrate these policies and to fund these policies, we need to show the metrics of it. So showing when there is malnutrition prevalence, showing the data about readmission rates, showing data about length of stay, and data about mortality rates. We need to keep on developing metrics on cost savings, because it's essential in the political discussion. Every time I've been talking with politicians at different levels, it's around 30 years that I'm doing patient advocacy at different level, regional, national, European. I can tell you from the city healthcare assessor to the DG Santé commissioner, they have always one thing in common. The first question they ask me is how much it's going to cost. So let's show the metrics on how much they're going to save. Let's show the metrics on how we can utilize resource and also which are the return on investment. We need also, by the way, to show the patient-centered metrics, otherwise it wouldn't be useful for me to be here. So we need to keep on measuring the improvement in quality of life, the functional status, and the patient satisfaction. Quality of life and quality of care must go together. So a few executive recommendations, and we go to the end. Established nutrition has to be an essential part of the healthcare process. We need to implement uniform screening and treatment pathways, align our reimbursement system with nutritional outcomes, build workforce capacity and nutrition competencies, deploy digital infrastructure and HR integration, focus on community prevention and equitable access, and track outcomes and enforce accountability, of course. We need to move from the concept, we need a shift in our mindset from reactive treatment to proactive treatment, to proactive recovery and prevention. So nutrition policy, at the end of the day, it is health policy. There are addressable burden, like the unmet nutritional care needs are widespread, but they are entirely solvable. We need to create a systemic impact and so develop policy tools in order to improve patients' outcomes and resource utilization. But success requires integration across the entire healthcare ecosystem. And patients need to be embedded in the designs of this system since the beginning. Effective nutrition policy transforms patients' care from reactive treatment to proactive recovery and hopefully prevention. Thank you.
Okay, thank you very much. Very insightful, and it's absolutely clear that at least some patients know exactly what needs to be done. Now I'm going to ask everybody to stand up, and I'm going to ask one in the audience to also walk over here. So we'll stand up and just raise a little bit, inspired by my list, okay? And while we're standing up, it's my pleasure to introduce my good friend and fellow surgeon from Poland, Stanislav Klek. You may now sit down. Now, Stanislav is also, he's the current chairman of ESPEN, which is the best and most important clinical nutrition organization, society. And he's here to give his views on a joint European perspective on nutrition care. Stanislav, please.
Good morning, ladies and gentlemen. Thank you very much for coming. And I wanted to, thanks for the very kind introduction. I'm surprised, you know, surgeon greeting surgeon. It's almost like surgeon greeting anesthetist. So it's very strange. Thank you for this. And yes, I wanted to welcome you all to this meeting on behalf of ESPEN, and I wanted to thank Anna for organizing it. It's a great event. And yes, I wanted to present you our perspective on nutrition health. And thanks to Mr. Greco, I actually feel like I'm called, you know, to give you this answer, what we're doing about stuff that you were presenting. So just a few words on ESPEN. ESPEN is a scientific society, of course, and we deal with all the issues relevant to malnutrition, undernutrition, nutritional therapy, nutritional support, and metabolism. We do this in the field of science, we do it in the field of education, then we also fight for, you know, for some quality standards and consensus statements. We are multi-professional, multidisciplinary, and international. We are the largest society in the world dealing with the topic of clinical nutrition and metabolism. We have around 4,000 members and we have around 5,000 people coming to the congresses, and we represent in total, let's say, around 80,000 of clinical nutritionists worldwide. And we are 47 years old, and it's a great honor for me now to acknowledge a previous chairman of our society, who are here in this very room with us, and starting with Professor Claude Pichard over there, Professor Andre van Gossum, and Ole Ljungqvist. Thanks to you, we are here where we are now. So that's what you're doing. So I'm really grateful, and I'm proud to tell people about ESPEN. Regarding what we do, this is the way I'm going to start answering the question of Mr. Greco, is what we do almost everything. We cover the aspects of science, of course, and the education. Regarding education, we're doing with the basic education, we do the advanced education, we do excellency trainings, we do workshops regarding science. We offer quite a lot of money for scientific grants every year, and we also organize symposia and, of course, congresses. I will not be going to details of all the activities because there are other speakers, they're going to address them. So just, you know, just to show you more things about malnutrition or undernutrition, and I think Professor Tommy Sederholm will explain this topic to you. So we are definitely recognizing the problem, and we've been doing this for years. And whatever you call it, malnutrition or undernutrition, we've been doing this, and we've been fighting undernutrition. In 2022, it was a kind of a summary year for these activities when the Vienna Declaration on Human Rights was actually published, and we said very, very clearly that nutrition is a human right. Everybody has a right to nutritional care because everybody has a right to health. So that's an obvious thing, but as Mr. Greco said, it is not really happening. At least it's not really happening everywhere. So from what we trying to also to say is we are doing this reality checks every other year, every several years, and we are trying to show the actual situation not only in Europe, but worldwide, but of course here in Europe we do the most of the works. And the situation is not something that we can be happy about. As you can see in this 2008 paper called EUR-OOPS, it was a multi-center study to show the importance of malnutrition and risk screening regarding the outcomes. Still around 1/3 of our patients is malnourished. And that's a fact. Now, it hasn't changed much over the last years, and we have to accept this fact, and we have to move forward. And thanks to conferences like that one, this is actually one of the major and fundamental points how to deal with these things. Just please remember, there are these reality checks, and we are not there yet in terms of fighting malnutrition. So first thing we're trying to, every year, all the time, we're trying to achieve is to recognize the problem and make this problem visible. And I already told you that Professor Sederholm is going to talk about the ICD-11 coding, but this is one of the ways we recognize the problem, and we named the problem very precisely. But another thing is, you know, what we've done about it. So we have taken actions, multiple actions every year, almost all the time. All of our committees, all of our workforce, work groups, and everybody actually is involved, actively involved with fighting malnutrition. And this is done everywhere. The problem that we have is that we are taking the problem at the last level, because we are taking the patient at the level of the hospitalization. So it is not really our goal to start doing things about the lower level. We, of course, been trying to do this, but that's, you know, this is the key point for us. So the moment the patient comes to the hospital, we are starting to deal with malnutrition. So raising awareness was already mentioned, but just let me tell you that we've been all over the place for raising awareness, not only with serious scientific activities, but also some more simple activities like, for example, Malnutrition Awareness Week or Nutrition ESPEN fact sheets. All of them are for free. All of them are available to everybody. It's just enough to go to the website and download them, and I distribute them. They've been translated to multiple languages, so you can use your own and national version. If you need your own language, this fact sheet in your own language is just enough to write an email to Sylvia sitting in the back of the room, Ms. Tarantino, and she will help you do it. And so please use them whenever possible. Education. It's not only fact sheets, it's also training centers, it's the LLL courses. For this of you who don't know, there have been already more than 100,000 people trained in LLL courses. 100,000 people trained over the last 21 years. So there's this initiative, there are workshops, there are training centers, all of them available to almost everybody. And of course, regarding science, it's not only about grants that I already mentioned, it's also about guidelines. And yes, guidelines are evolving. Yes, we are adopting guidelines to real-life scenarios because we think that's the only way to deal with this problem. And we update them regularly, and we always verify them in terms of scientific value. Next step that we've been undertaken some years ago, and is actually probably this year, it is actually paying off, at least in some countries, is the education for pre-graduate medical students. So nutrition in medical schools. The initiative is called NEMS. Right now, as we speak, in Poland, there is a regulation passing on nutritional education in medical academies. There will be 40 hours of education on clinical nutrition in our medical universities, and we will definitely use NEMS material. Again, it is enough to register to the website, and you can get them for free and distribute them in your high schools, and we'll use them because they are very, very effective in terms of education. We, of course, we cannot achieve this without cooperating with other societies, and believe me, several. And there are new ones coming, like this month, because it's the 1st of June. So the end of this month, we have a common session at the Multi-International Association for Supportive Care on Cancer Congress. So that'll be the first of these activities ever. And we started to talk to other societies as well, not only this one that we can see here. This is like a mixture of all these organizations, industry-related, not industry-related. By the way, thanks to the MNI, we make another big step forward, for example, in terms of cachexia definition. So yes, that these things are going, so we are actually trying to fight malnutrition very actively. And of course, we are non-state member of WHO Europe that also facilitates fighting malnutrition. We do it along with EFAT, and I think that's one of the most important initiatives. And we are reaching out to find new topics, to find new areas that we have to address. One of the newest initiatives is this one, because this was the webinar that was held in April about the treatment of post-ICU patients. That's something we very often forget, but unfortunately there's around 10 to 20% chance that anybody in this room will get to the ICU during their lifetime. So the risk is actually quite high. And after surviving ICU, we have to go back to work, go back to regular life, and go to everyday activities. We cannot create victims. We have to create winners, not only survivors. So that's another step. And one thing also worth mentioning here regarding the building the awareness, this webinar was done by our early career faculty members. So we are trying to get new young people into the field, because you know, clinical nutrition is important. It's a super platform for professionals, but it's not that sexy as, for example, endoscopy for surgeons. So we need to show them, you know, why it matters and why they should be dealing with nutrition on everyday basis. So with all this being said, I think I convinced you that we are actively fighting malnutrition. And Mr. Greco, I promise you, we will do better. We will do better, we will fight harder, and we will be stronger. So we will beat malnutrition. And with that being said, please come and join us in Berlin for our Congress in September. This is probably going to be the biggest Congress ever in terms of attendance, so you're more than welcome to be there with us. Thank you. And thanks, Zena.
Thank you very much, Stanislav. And now we move to the last speaker. So that is Grigoris Rivas. And this gentleman is from Greece. He is the president of the European Federation of the Association of Dietitians. So now we're getting another very important group of people that can help us in moving this forward. So, Grigoris, welcome, and the stage is yours.
Thank you, Ole, and thank you, everyone, for being here today, and of course, European Nutrition Health Alliance for organizing this exciting, or we hope it will be exciting and interesting event. So about IFAD. IFAD is a federation of associations of dietitians. We represent around 35,000 dietitians through our members. Our members, we have the national dietetic associations, and also a lot of HEIs, so higher education institutes that educate dietitians around Europe. Last year we were in Athens for this Congress, the ONCA one, and I have talked for the first time about the IFAD Budapest resolution. So this is a resolution that comes after the Vienna Declaration that Stanislav, Professor Kleck, talked to you about earlier, about the fact that nutrition care, dietetic care are a human right. So we have done, on the same year in 2022 in Budapest, we have drafted this resolution and voted for it. All the national dietetic associations that are members of IFAD that have to do with how we can realize this human right of nutritional care around Europe. So there were some commitments. We have talked about them in more detail last year. This year, what we did is we had an add-on, an addendum to this, an extension to this declaration that also tried to incorporate the fact that our commitment to have food, to have nutritional care, to have food as a means, as an essential mean for health, dignity, and survival, embedded in all situations, not only the regular or hopefully regular and normal situation that we have in most European regions of peace and tranquility, you know, and evolution and everything, but also when oppression or war are a reality in certain areas or certain countries. So again, what we try to make very clear with this extension to our Budapest resolution is that food, being a human right, cannot become a tool of oppression or you know, a weapon of war. Having said that, war, illness, and other such situations are possible agents that can create undernutrition, and that is why we are trying to work more closely with SPEN and our and the other members of the multi-professional teams in hospitals and other health institutions. And also we're trying to work with our patients to reduce or prevent malnutrition or undernutrition. As we are now defining it, you can see that we have started some work with one of our expert groups, that is the European Specialist Dietetic Network of older adults, and they have created a statement back in 2024 that had to do with prevention and management of malnutrition in dementia, and this is just one example of the work we have done. Also, we are working closely with our European Specialist Dietetic Network on oncology, and we are trying to work more efficiently on having the right guidelines out there and the right documentation out there to help in the cure of cancer, but also in the whole continuum. So that is why this week, during the European, that was the European Week Against Cancer, we had a very good communication campaign having to do with what dietitians can do in this fight, and we have our communication manager here, Mariana, that has produced these materials together with our partners, with our colleagues in the ESDN Oncology. So you can see, if you haven't seen the messages till today, I hope they were not only stories, that they have remained in our main page in Instagram. So you can see that we have messages, and we are trying to describe our role also to patients and not only to colleagues on various issues concerning cancer treatment, like access to medicines and supportive care, how we work closely with patients and survivors and break any misconceptions that are out there, and unfortunately for cancer patients there are a lot. How we work on research on oncology nutrition, and there are a lot of colleagues out there around Europe that are working together with doctors and other members of research groups on providing more evidence on how we can integrate nutrition into the care pathways for cancer, and also about digital health, which is a very it's a modern issue, but it is also a great tool. It can be great help for all of us when we're trying to deal with communicable diseases. We have the example of how we can use digital tools for cancer patients and also for prevention, but we can use these tools for all other non-communicable diseases. We are also trying as IFAD to work more on the prevention and the food policy side. So apart for being a state actor, a non-state actor, sorry, in WHO Europe, working very closely with ESPEN as well. We have an observer status in Codex Alimentarius, and we take part in various consultations. So this very recent one was about development of dietary guidelines, and we tried as dietitians there to give the main facts that we need to work on when we're having new guidelines, because in the past guidelines were heavily based on policies, on political will and issues, and also on what kind of foods each country is producing. But now things are changing. Dietary guidelines have to be more about health, have to be more about sustainability, at least in Europe, because in the US we are seeing a different trend, but let's stay in our continent. As far as other policy issues are concerned, you can see here, and of course in our website and in our social media, our response to the EU consultation on the audiovisual media services directive, and we are talking there more about how we can influence marketing to children, brand advertising, also more about alcohol and how and access and advertising of and marketing of alcohol, which is an issue, and we are taking part in the alliance against alcohol that has been promoted recently by WHO Europe. Of course, we are working, as I said, closely with ESPEN on the new guidelines. We are also trying, and we hope we will have news to share in Berlin on some practical add-ons on the existing guidelines. along with Aspen colleagues. We have worked on GLIM on the past, and finally about sarcopenic obesity. We have seen the very recent publication in clinical nutrition. We are again working on how to implement this call to action having to do with the nutritional agenda connected to sarcopenic obesity. So there are initiatives out there. We are trying to listen to what our colleagues and our patients are telling us, and we hope we will do much more. That is why we are in all these multi-professional meetings and fora, so that we can exchange knowledge and go further ahead. Thank you all.
Stay. Is it? Yeah, okay, good. No, I thought it's high time to involve the audience a little bit. And I'll just give a warm-up question here, because now we have time for questions. So I'd like to ask Marco, now, you gave a display of what you would like to see. And now you listen to two leaders in two very important organizations. What's next? What are your immediate reactions?
The reaction is positive, of course, but not surprising, because I know what they are doing. The point is that we need to enforce the collaboration in order to make this reality all over Europe. So I think the joint effort of these three organizations and all the other organizations and people that we do represent is to convince policymakers that this is a necessity and it has to happen now.
Okay, so how do we get to the top people? I'm going to ask a good friend over here just to give us a few words on how to reach the government.
Yeah, I think it's important to have those international efforts, the guidelines, the evidence, and to have the general awareness, also to convince, for instance, WHO, but to have changes in your hospital where you live, you need regional or local or national people convinced. And this is sometimes not easy. I think what is necessary is to create networks. When I come with a nutrition society approaching a member of parliament, then they will listen. If I come together with, for instance, representatives of cancer societies or patient representatives together with gastroenterologists, diabetologists, or what else, and so we are a group of people, all with the same message, then the likelihood that the people will listen to us increases. That's our experience in Germany. I will talk about later about this. So I would say create national networks with others to have a strong common voice.
Super, that's what we're doing right now, right? So, okay, I'll bounce back the question to Stanislav. You saw the list from Marco. You answered a little bit about what you're doing. What are if you could just pinpoint a couple of things that you think would be particularly good to work with patients?
Yeah, well, I'll be brutal, but first thing we should do is break this bubble here and reach out. Because I can recognize at least 50% of all faces in this room. So that is also answer questions that Matthias was starting to answer. The problem that I see, I mean, the key point for me would be first, make European leaders believe that it matters, and then unify the same approach for all, at least all European Union countries. And this would help a lot. I have no idea how to do it effectively. I know that, you know, we've been trying, but this is kind of disappointing, actually, you know. It's all about saving money last months and last years. And Honestly speaking, you know, when we talk about when we talk about clinical nutrition, most of the countries here, we already have resources. It's already been reimbursed in most of our countries, and we just don't use it. We undervalue clinical nutrition, and this is the key point. Change this.
Yeah, we just heard earlier on here from Jean-Pierre about how they're working here in France. They even have a governmentally sponsored organization to push for policies. And still you said that you're not able to pull through even for things that are extremely cost-saving and beneficial for patients. How would you like to address these people so that we can work together and move things forward?
Thank you for your great efforts, and it's very impressive. I think you have to align planets. And so you have several moving parts, one of them being the economical model of any healthcare system. So if it's misaligned, it won't work. So the question is, how do you rearrange the economical regulation to favor what is really cost effective, which is the point you've made already for several years, by the way. I think we have to start with evidence-based policy, and we have to communicate on that. That's what you're doing, but it does not work well, actually, because the willingness to pay is biased towards what is taken as a technological innovation per se. And so, to go back to my implicit criticism, what's going on at the European level is that some of the stakeholders have much more power because they embody the technical innovation in a very strong way. And that's why it goes alongside with the extension of commercial determinants of health to the regulatory bodies. And we have to be very conscious of that, including some of the guidelines may be co-written by the industry. They have the right to do so, but you have to take into consideration that those guidelines could be biased in the interest of the industry. And it could be good in a way because the industry is contributing to progress, but from a regulatory point of view, it's not always a strength. And so that's why I will end up by you have to have voice from non-conflicted bodies to really ameliorate the situation and push forward as you're already doing. So if we could help, we'll help.
Thank you. Gregoris, now you've listened to our patient representative, Stanislav, Espen, the leader. So, and you're hearing that we got to learn about the economics about to be able to really push things. Mm-hmm. So how can the dietitian organization, what's the most important role that you can play here, do you think?
Well, you know, dietitians have something very positive or unique to bring on the table. That we can have a very good, fruitful, results-oriented relationship on the same time with our colleagues, with health professionals, and with the patients. Why? Because you know, a dietetic consultancy will take at least 20 or 30 minutes, so you have time to have rapport with your patient.
Could you
so
play
you know,
a role?
No,
I just wondered, could you play a bigger role as teachers of nurses and nurses' aides and
of
other
course,
people? Yeah.
Of course, because there's a being an educationist is also a big part, an integral part of our basic training. So we are educated to be both educators and clinicians. So yes, of course, and I understand that you cannot have, you know, dietitians for in every part of the of where nutrition is discussed within the healthcare system. So of course we are ready to educate nurses and other healthcare professionals in order to make the whole process more results-oriented. But I wanted to comment a bit on the fact that had to do with what we can do to persuade politicians or decision makers. I believe that there is not one recipe we can follow throughout Europe. We must try to, of course, to consolidate, but different national or let's say regional examples of how we could be working with decision makers, and of course taking into account that you cannot do anything without having some kind of, not conflict, but interests within the group. So we acknowledge the interests that are there from private players, from decision makers, from scientists or healthcare professionals that have their, or we all have our own interests, take those into account, try to find a way on the national or regional level to be more communicative, to bring on better results and become flexible on the way we work on the various sites. We just need to be focused on the same results, to be certain that we all aim for the same thing. If we aim for the same thing, we will find a way to go there, being flexible, because it depends every time who you have opposite you, because there are interests, always.
I think you're absolutely right. I've been doing a lot of implementation work of enhanced recovery all over the world, actually, and I can tell you every hospital is different. So, so every country will also be different. So you have to find them where they are and then take it from there. I know, Stanislav, I'll give you the
Just
last
as a comment, I was actually going to mention your work with the ERAS protocol and your education, but you've done that already. But I agree with Grigoris to some point, but some truths are universal. For example, what we learned from effort trial is that actually we can save the number needed to treat is 37. So with a proper nutrition in 38 people, we can actually save 1. So this is a universal truth. And this is worldwide. I mean, this can be translated, of course, into national settings, but this message is there. And we need to get with this message to our policy makers. And then I agree with Grigoris, we can go downwards and maybe address some specific points in each country. But universal truth is already there.
No, I think the science is very clear and the economics is also very clear. Okay, what is additionally very clear is that we're going to have lunch outside and we're going to have a break until 2 o'clock. And for the online listeners, please come back at 2 o'clock. We'll continue the deliberations. And hang on just a second. Now we're going to move into a very important change which is coming that we mentioned early on. It's the ICD-11. So the next session will be focusing on how we can leverage that to take things further now that we've recognized what we have and where the problems are. Okay, so I'd like to welcome everybody back in and also our online listeners. And in particular, I'd like to welcome Claire Ferrand, who is the public health nutritionist and the WHO representative to the European Union. She is going to start off our session about WHO's ICD-11 with nutrition coding in clinical setting, and we're going to be discussing European strategies for implementation of this very important step forward for nutritional care. So without further ado, I see you're ready, so please I'll just hand over to you, Claire. Welcome.
Thank you. Good afternoon. And firstly, thank you very much for the opportunity to contribute to this discussion. I'm sorry I can't join you there in person, but I'm very pleased to be able to join you online. As you know, nutrition is really fundamental to health, well-being, and healthy aging. And across the WHO European region within which I work, nutritional care is increasingly recognized not only as a component of disease prevention, but also an essential part of disease management, recovery, and quality of life. And so today, I will briefly discuss the broader policy context, including non-communicable diseases, healthy aging, how this links to the Sustainable Development Goals, before highlighting some of the work that's underway in our region to strengthen nutritional care. And I will conclude by presenting slides which have kindly been put together by our colleagues at WHO headquarters on ICD-11 coding developments. And I'm very pleased that I'm joined by the technical lead here with us this afternoon. Next slide, please. So non-communicable diseases, as many of you may know, are the leading cause of mortality and morbidity in the WHO European region. And they really account for the vast majority of premature deaths and disability. And every year, they cause 1.8 million avoidable deaths. So these are treatable and preventable deaths in our region. Next slide, please. And nutrition is a major determinant of NCD risk and outcomes across the life course. Poor diet contributes significantly to cardiovascular diseases, type 2 diabetes, obesity, and several cancers. And while much of the attention rightly is given to the role of diet in preventing these non-communicable diseases, nutrition also plays a critical role in the management of people already living with these diseases or these conditions. And as populations age, maintaining good nutritional status also becomes increasingly important for preserving functional ability, supporting healthy weight, supporting healthy aging, and improving quality of life. Older adults living with NCDs are particularly vulnerable to disease-related malnutrition. And this really highlights the need to view nutritional care not only as a prevention strategy, but as an essential component of the integrated person-centered care for people living with NCDs throughout the life course. Next slide, please. Improving nutrition is central to achieving the Sustainable Development Goals, particularly Sustainable Development Goal 2 on ending malnutrition in all its forms, and 3 on ensuring healthy lives and promoting well-being, as well as reducing inequalities. And disease-related malnutrition is especially relevant because it really sits at the intersection of these goals. Next slide, please. And disease-related malnutrition is commonly an underdiagnosed and undertreated condition. It's prevalent in patients with nearly any disease, older adults, as well as those living with non-communicable diseases. And it's estimated that it affects between 30 to 50% of hospital inpatients. And it's particularly common amongst older adults and those living with chronic diseases. And we know that the evidence shows that nutritional care can effectively prevent or treat malnutrition and improve these disease outcomes. However, access is still limited for many patients. And despite it affecting between 30 and 50% of hospital inpatients, it often remains invisible in routine health information systems. And this is why the WHO Regional Office for Europe, within where I work, together with experts, including the European Society for Clinical Nutrition, wanted to generate awareness and a call to action. And we published this fact sheet which I can share the link for, and convened a webinar which brought together experts, clinicians, and policymakers to really raise awareness of this important issue. And these activities really aim to encourage stronger integration of nutritional care into routine clinical practice. Next slide, please. Disease-related malnutrition is an important example of nutrition-related conditions. It's not the only nutritional challenge facing health systems today. And as populations age and the burden of non-communicable diseases continues to increase, we are also seeing a recognition of more complex nutrition-related conditions, including sarcopenic obesity. Sarcopenic obesity highlights the challenging nature or the changing nature of nutritional care needs in our region. And it's characterized by the coexistence of excess adiposity and low muscle mass and function. And it's increasingly observed among older adults and people living with NCDs and multimorbidity. And so WHO, alongside leading expert organizations, also developed the fact sheet on addressing sarcopenic obesity in our region. Next slide, please. Highlighting some of the challenges and solutions. And so this fact sheet really aimed to improve awareness, to support earlier identification and strengthen integration of nutritional care into clinical practice and health systems. And improved recognition and classification of sarcopenic obesity is also important for health information systems, surveillance, and implementation of the ICD-11 coding. So, like disease-related malnutrition, sarcopenic obesity also illustrates the importance of improving recognition and classification of nutrition-related conditions. And without consistent identification and documentation, these conditions remain difficult to measure, monitor, and address. And so this really brings me to the role of ICD-11. Next slide, please. And so with thanks to colleagues from headquarters, I will now share the following information on ICD-11. So next slide, please. So why does ICD-11 matter for nutrition? It's a key enabler of better nutritional care is obviously better data. And ICD-11 is the International Classification of Diseases. It's in its 11th revision, and it's the global semantic standard for health data and is governed collectively by all 194 WHO member states. It provides a common language for recording, reporting, and analyzing health conditions across countries and health systems. And this is really essential for ensuring consistency, comparability, and evidence-informed decision-making. And for nutrition, ICD-11 represents an important opportunity to improve the visibility of undernutrition and other nutrition-related conditions within this routine health information systems. So the introduction of the new ICD-11 entity for undernutrition in adults reflects growing recognition of the clinical and public health importance of nutritional status and nutritional care. The improved classification supports more accurate diagnoses and documentation. It facilitates comparability across countries and settings, and it strengthens our ability to understand the burden of undernutrition and monitor progress over time. And so ultimately, the better data can help drive better policy, better planning, and better care for people affected by undernutrition and disease-related malnutrition. Next slide, please. So the key improvements for ICD-11, an important development for nutritional care is the continued evolution of ICD-11 and the improved classification of nutrition-related conditions that I mentioned. So a notable example here is the new ICD-11 entity for undernutrition in adults, coded as 5B72. And this classification includes 3 etiology-based subtypes, so recognizing that adult undernutrition can arise from different underlying causes and clinical contexts. And this supports a more clinically meaningful and patient-centered approach to diagnosis and to management. The new classification also enables post-coordination, allowing documentation both of the underlying disease and severity of undernutrition. So this provides a more complete picture of a patient's nutritional status and healthcare needs. And importantly, the ICD-11 structure has been designed for use within electronic health records, and it's supporting that improved clinical documentation and data collection across health systems. This new entity is expected to be included in the stable ICD-11 release from 2027. Next slide, please. So just to show where the new entity is located within the ICD framework, this appears technical, but the placement is important because the classification influences visibility. And so the revised classification allows for more detailed and clinically relevant coding. Next slide, please. The placement here of the disease-related malnutrition, again, is important because of the visibility. And when conditions are clearly defined and appropriately classified in ICD-11, they become more likely to be recognized, diagnosed, recorded, and measured consistently across health systems. And this provides a foundation for integrating nutritional care into routine clinical practice and health information systems. And importantly, it supports more consistent data collection across countries, enabling a better understanding of the burden and informing the policy and resource allocation. Next slide, please. So one of the major advances is the post-coordination. So as I mentioned, this allows clinicians to move beyond the simple diagnosis and capture a fuller clinical picture. For example, linking undernutrition to an underlying disease and recording its severity. So this better clinical data really supports better patient care and better health data. Next slide, please. So as I conclude, there are key messages that I'd like to leave you with today. First, disease-related malnutrition remains widespread across health systems, yet still frequently under-recognized and underdiagnosed, and too many patients are affected without their nutritional needs being systematically identified and addressed. Second, the limited visibility in health information systems has in many ways constrained our ability to fully understand the burden of disease-related malnutrition and to advocate for the investments that are needed and the policy attention it deserves. And so ICD-11 represents a really important opportunity to change this. And the new coding framework has been designed for modern clinical practice and electronic health records, making it easier to document nutritional conditions in a more meaningful and standardized ways. And I've included, although I haven't really touched on this example, but countries do not need to wait for the whole system ICD-11 implementation before beginning to benefit in specific clinical areas. So experience from countries such as Scotland demonstrate that implementation can begin incrementally. Scotland started with mental health in 2022. So one domain can move before the others. And finally, and maybe most importantly, the classification is not simply a technical exercise. The correct conceptualization of disease-related malnutrition is fundamental. Clinical benefit begins with recognition and diagnosis, and when nutritional conditions are identified, they can be assessed, managed, and monitored appropriately. And improving this diagnosis, coding, and documentation is is not the end in itself. It's a means of strengthening nutritional care by generating better data, informing better policy, and ultimately improving outcomes for the people that we serve. So I'll end my presentation here, and thank you very much.
Thank you very much, Claire, for an excellent initiation of this session. Now it's my pleasure to introduce to you Tommy Cederholm. He's a retired professor of nutrition, geriatrician from Uppsala, and he's one of the people who has been actually making this happen to begin with. So I leave it to you, the floor. Please, Tommy.
Thank you, Olle. Great to be here, talk to you. And thanks for the presentation that we already heard. It provides an excellent basis for my talk, which in parts will be a little bit overlapping. But I will try to give some insights into, well, of the course and the communication between the clinical nutrition community and WHO in order to come up with this new code that will be very important. One of the starting points, of course, we've been part of this community for many, many years, and we've tried to improve all the time. One of the later starting points, perhaps, is this SFN guidelines on definitions and terminology that came out 2017 that clearly established that we have kind of 3 pathological pathways to the undernourished situation. We have disease-related malnutrition with inflammation, without inflammation, and of course we also have malnutrition without disease, which in many ways assemble or resemble the disease-related malnutrition without inflammation. This is a well-established template for malnutrition. It also indicates that malnutrition, as we have called it, is a complex condition. And of course, it provides a challenge to come up with a consensus on how to diagnose it. So, well, during the time I've been active in the area, these are at least, well, these are some, perhaps the major efforts that have been introduced in order to come up with a potential global consensus, and those marked in red, they are still out there. SGA, PGSGA, MNA, the MUST, the MNA short form, the NRS 2002, and they all work, and people think that they are good, and they are good, but I think we also agree that this lack of consensus is a problem for our community. I think the credibility for us, for that we need to come up with a consensus on the diagnostic criteria. So just after that definition paper came out, representatives of 4 major societies, ESPEN, ASPEN, the Latin American FELAMPE, and the Asian PENSA, came together, and during a 3-year period between 2016 2019 worked in order to come up with something that we could agree upon, which came out as the GLIM, the Global Leadership Initiative Malnutrition Criteria for the Diagnosis of Malnutrition, a paper that was published in 3 major journals. And the basic aims for GLIM was to come up with something that is easy to perform, use objective measures, it should be applicable in any setting, in any condition, and it should, because it has also to be applicable in low resource settings, independent from biochemistry and technical advices. So this is a schedule, I think you're well aware of this scheme, where step number one is screening for malnutrition, and of course if you have identified someone with risk, you subject this individual to the 5 criteria that came out from that consensus process to be the core clinical undernutrition criteria. 3 phenotypic criteria: weight loss, low BMI, low muscle mass. And the etiologic criteria would then be decreased food intake or disease burden, inflammatory burden. And to meet the criteria for being malnourished, you need to fulfill at least one of the phenotypic and at least one of the etiologic criteria. And as we heard, we also have the possibility to determine severity and, of course, also to label the form of undernutrition, whether it's inflammation or non-inflammatory related. To relate this to ICD-11, I think it's important to say that the GLIM model is really a fusion of all existing tools. So if you are very convenient with working with one method or one tool, we think, or I think, it is really not a big challenge to adapt that working method to the new ICD-11 code. But of course, the new ICD-11 code is very much influenced by the GLIM criteria and the GLIM model. Obviously, the GLIM model has received a very strong support. We have more than 4,000 citations at the moment, and we have papers showing a very strong validity of this method. And also, it has been decided that at least every 5 years, the model should be updated due to upcoming knowledge. So that is kind of the basis for the reason when we came up, the clinical nutrition community was able to come up with this kind of consensus. Of course, we need to communicate that with the WHO. And as already been stated previously, the International Classification of Diseases is it's really the basis for statistics and for reimbursement and everything. And the ICD-11 was really decided in 2019, but WHO doesn't expect it to be implemented until not earlier than 2027, perhaps in 2028. WHO usually don't, usually don't communicate with professionals. They communicate with representatives of governmental bodies in member states. So Elisabeth Rothenberg and I, we contacted the Swedish Classification and Terminology Office at the National Board of Health and Welfare, and we had a very strong support from the officers there. They understood our problem, and they were really the one to introduce us and to start the communication with the Geneva ICD department. So in 2020, that's more than 6 years ago, there was a proposal sent to WHO that was supported by more than 40 nutrition societies. There were patient organizations. It was, of course, ESPEN, it was IFAD, and all of them. And it was, I heard somewhere that this is one of the strongest ICD-11 proposals ever submitted to WHO. And it was very clear that they were very keen to listen to us, although we usually communicated through our Swedish governmental officers. And you can see that the proposal at that time was called malnutrition in adults. And we had these 3 pathological pathways that we have discussed previously. It took like 6 years. The WHO bureaucracy is not very fast, but of course they know that it will happen. It will wait until we have to wait until 8 years until it will be into action. So we can understand now retrospectively that they were not as keen as we were at that time. But October 25, there was a positive decision taken. And it was decided that it will become official in the first ICD-11 update of 2027. Interestingly, which of course is something that we have to discuss and how to relate to, is that the WHO, they really demanded that you cannot use malnutrition. We don't accept it. Because for them, malnutrition is a too wide, broad concept. So they said, you call it undernutrition or we skip it, something like that. Well, of course, polite discussions, but it was so clear that they would not accept malnutrition. And that is, of course, something that we have to discuss how to relate to. I had actually a communication this morning with one of the officers from the Swedish classification office who had been in contact with WHO yesterday. And they are also very keen. They see this as a breakthrough, actually, because, well, of course, they see it as a breakthrough. One reason is because it's such a strong support from the clinical nutrition community. So they really think that they want to be part of the implementation work ahead of us, which I think is great news for us. So the decided ICD-11 amendment, I will not go through this again, but as you can see, it's very close to the GLIM concept. Combination of phenotypic criteria, weight loss, low body mass index, or low muscle mass, with one of the two etiologic criteria. And we have the 3 subcategories, and we have post-coordination for moderate and severe. So I really want to thank Dr. Magdalena Fresca and Christian Frank at the Swedish CDC office, because without their help, we have not been able to do this. So let me conclude. I think the pros for a uniform diagnostic model for adult nutrition is that it provides an increased credibility in the medical community. It will increase or facilitate communication between various specialties with WHO, with financing bodies. Of course, we can also compare prevalence figures globally. Increases credibility for reimbursement issues, and of course also it will facilitate science and learning. Of course, now we have challenges in front of us. There are a lot of legal actions that perhaps is, well, where we can be part of. One of them is, of course, that the member countries have to decide when to start with the ICD-11. Most countries will probably not do it before 2028. That's what I understand. Meaning also that you have to update your DRG registration routines, you have to communicate with national CDCs, and of course also to align and discuss with funding bodies like, well, in Scandinavian countries, we have public healthcare funders, and otherwise you have to discuss with insurance companies how to do this. And of course, I think for us, and I think Ulle will probably say something about that we need to start awareness campaigns. We have to discuss how to align these criteria with current diagnostic templates. And of course, we need them to update educational curricula and everything, but that will take time, no problem. So with that, I thank you for your attention, and I'm looking forward to the discussion.
Thank you very much, Tommy. It's a lot of work behind it, and I know Elisabeth Rothenberg also played a very important role in this work. So a special thanks to her as well, because this is really a major breakthrough. So now, what does this mean for patients? I think that's a very relevant question. So we asked this question to Karen Castrati. She's the chair of the Patient and Nutrition Impact Group, and I know she's working with kidney cancer, right? So the floor is yours, please.
Well, thank you. Thanks for the introduction. Yes, I work as a patient advocate with a kidney cancer organization in Germany and also on the European level. And I have been asked to bring in the patient perspective on the ICD-11 implementation. So let's just start with the hidden burden of malnutrition, I call it. We have all heard the numbers and figures today. It's a huge problem. A lot of people worldwide and in Europe are affected by malnutrition. 30 to 50% of the hospitalized patients are malnourished or at risk. And we already heard today that this is linked to poorer recovery, complications, longer hospital stays, and so on and on. But I think what we should not forget that behind all those numbers are real people, it's patients. And in our organizations, we see that patients are really suffering. Cancer patients, I mean, they come to us, we talk to them, and we see that over the therapy weeks, they lose a lot of weight. They're getting less and less, they're getting weaker and weaker, and it seems that they're not receiving nutritional information, that they're not receiving help, that they're not even receiving screening. And when we asked them, did your doctor screen you, did they say anything? No, nothing happened. So this is something I think we as patients and as a whole community working within nutrition should not accept. This should be on our agenda. And I think the current challenges, as I just said, is that nutritional problems are often overseen or identified too late and then remain untreated, and that's crucial for patients. When it comes to cancer patients, there are numbers out there that every fourth patient is dying from malnutrition and not of the disease itself. So this is really frightening. When, as a cancer patient, you see those numbers. And then it's also the fact that nutrition care may depend on where you're treated, where you live, in which country, in which region, in which hospital you are treated, or even which HCP is treating you. Some are aware that it's important to cover nutrition, others don't. So we think that documentation is crucial, and right now, documentation differs between hospitals, countries, regions, and also after when you leave the hospital. I mean, there's no documentation about your malnutrition when you leave the hospital. It's just gone. No one knows, and outpatient care does not involve it then maybe. That's the last point I had here. Nutrition needs are not always reflected in discharge summaries or records. So when the patients leave the hospital, they're left alone again. Maybe in the hospital they got treatment, but then out there, they don't. So why implementation ICD-11 nutrition coding could be important or would be important for patients? The first and most important thing is that it makes nutrition and malnutrition visible within the healthcare systems, and also measurable, I think. We would get more numbers. Right now, I think the malnutrition scores we have, they're just like estimates, because a lot of dark numbers are out there. A lot of patients are not diagnosed, are not documented. And that's also important to improve awareness and acknowledgement of nutrition-related conditions and malnutrition and the risks patients face. It's good to have the ICD-11 coding to support early identification of patients at nutritional risk, of course, and also to strengthen the continuity of care across settings and countries, as I just mentioned, maybe once you leave the hospital, or when you go from one doctor to the next. With cancer patients, we see a lot that they go from the oncologist to the HCP next door, or to the hospital again. So it's a lot of people involved, and there's no continuity across those pathways. For patients, it's really important because right now nutrition problems remain under-recognized in clinical care. Many patients feel that nutrition is treated as secondary to treatment outcomes. When they go see their HCP and tell them, oh, I have a trouble with nutrition, what can I do? Mostly they get the answer, oh, you can eat whatever you did before, just do whatever you did. So that's not really satisfying because they're losing weight, they don't get help. So they feel they're not seen, not really seen. And if there would be some kind of coding and it's documented, it's different. My condition is stated in the records. It's not just my fantasy, it's real, it's there. Without coding, as I said, nutrition is often invisible in healthcare systems. And I believe ICD-11 can help make nutrition a recognized part of patient care and can improve access to screening and treatment. Even if the implementation might seem more expensive right now, I mean, budget is always a topic. That's what we heard all day morning, all all the day today so far. So even if it's more expensive right now, on the long run, it might support the financial system and the financial burdens when it comes to patients' treatment, because earlier intervention leads to reduced complications and maybe shorter hospital stays, less hospital readmissions. And it might also improve recovery faster. I mean, a patient might recover faster, and that's not a point only about budget, but it's also about quality of life when you think about the patient again. Then, of course, standardized data would support smarter healthcare planning and resource allocation. If you have it documented, you can count it, and then you can plan with it. And investing in nutrition recognition can improve long-term patient outcomes, of course, and also short-term when we talk about quality of life. Then, as I already said, what's really important for us as patients, I think, is the impact on awareness and acknowledgement. As I said, coding helps healthcare professionals to recognize nutrition as a part of treatment. Nutrition-related conditions become visible, and we can use this visibility in further political discussions and in policy change. Data from ICD-11 could even support research, advocacy, and also maybe work on the reimbursement systems. We know that in a lot of countries, nutritional supplements are not reimbursed, so this could help as well. And as I already said, patients feel their experiences and needs are acknowledged. And that's really important, I think, when we work with patients, to have them as a partner and to have their needs and their problems acknowledged. Patients want care that considers the whole person, not only the disease. So nutrition needs to be a part of that, because nutrition affects everyday life. It affects quality of life, strength, recovery, independence. For patients, it's really important. We need to eat every day, and if we have problems with nutrition, quality of life is just gone. And also, I think ICD-11 can support more personalized and multidisciplinary care, because when it's documented, all doctors, all your care team has access to the data and can support you, maybe hand in hand, not just a single nutritionist that's working on you, but also your doctor maybe supporting from the other side. And my last point on this slide, which I think is really important for maybe everyone here in the room, is that patient involvement is essential when we talk about a successful implementation of ICD-11. At least that's my point of view. But why would patient involvement matter? Maybe you think now, why should we involve the patients? Because it's their life. The patients provide real life perspectives on implementation and on the whole process. Patient organizations can support you when it comes to awareness. I think when it comes to implementing new coding, new things, it's always good to have awareness, widespread awareness, and patient organizations can help you. They can support, they can educate on the topics, they can educate the patients, and they can also educate the HCPs they're working with. And I think the implementation should focus on people, not only on systems. So that's why the patient voice matters, to bring back the people in all the process. And the partnership improves trust, adherence, and on the long run, quality of life. And why should patients help you? Why should patients be there for you? I think it's just, as nutrition is important for patients, it's important that there's a routine nutrition screening that's timely, that's early, and an early intervention to help the patients. We should have equal access to nutrition across Europe, the whole Europe, and not just several countries. And it should be recognized that nutrition is a part of the treatment, not an optional extra. And of course, in the long run, as I already said, there is a better quality of life, recovery, and the dignity in care when patients are heard. So my take-home messages for today is, if nutrition is not coded, it's often not counted. If it's not counted, it's difficult to improve. ICD-11 can help make nutrition visible, acknowledged, and actionable. And for patients, this is ultimately about better care and better outcomes. So thank you very much for your attendance.
Thank you very much, Karen. I think this is extremely important, of course. Now, the last speaker of the session is Philippe Scheutz. He is the chairman of a department, so he has to control the money somehow. So we asked him to discuss, is this really cost-effective nutritional therapy? Please, Philip, welcome.
Yes, thank you very much, Ole. And also for me, I'm very happy to be here. Beautiful place here to speak about... Oh, I need to press, huh? Yeah, beautiful place here to speak about this important topic. And of course, cost effectiveness is not a topic that is so easy to speak about because there is a lot of concepts behind that. Costs, what are costs, primary costs, secondary costs, what are effects, which effects are we comparing here. And in the end, I think it's very important as a payer, as a patient, to consider where do I spend my dollar? Do I spend it in a new chemotherapy for cancer? Do I spend it for prevention, or do I spend it for the care of nutrition? And I think this is a very important issue, and I'd like to share with you some thought about that. So when we, of course, speak about cost effectiveness, we have two parts here of the puzzle. One of them is the costs, and the other one is the effectiveness. And I think I want to start to speak about the effects of nutrition. So what are the effects and what is the efficacy of nutritional treatment? And then we can correlate it with the costs. Now, I think it's important to see that today we really have a lot of data showing that nutritional care is highly evidence-based intervention with very positive outcomes in regards to medical outcomes. One of the studies that was important to show this is the EFFORT study. Many of you have heard about the study and seen the results of the study. And it was important because it was the first large trial that actually compared patients that were in usual care, so they went through the hospital stay without receiving nutritional care, to patients that received nutritional care. And the trial asked the question, well, do we see differences in clinical outcomes in these two populations? Now, the study also provides some protocol, some guidelines, how could we manage patient in the hospital setting. And you see, this is the protocol that was used in the trial, and I think this is pretty much how we today also treat our patients in our hospital in Switzerland. So the step one is, of course, screening. So when patients enter the hospital, it is very important for us to realize within 24 hours which patients have a nutritional risk and which patients do we have to do additional nutritional assessments. So the second step in the trial and also in our clinic is then to define nutritional goals in these patients. So what are energy goals? What are protein goals? Do we have other nutritional issues to then adapt in these patients? And then the third step in the process is then nutritional intervention. And intervention means, now for my department, I'm the head of the medical department, so nutritional intervention means about 90% of patients receiving oral nutritional care, meaning that the team of the dietitians, of the hospital kitchen, of nurses, of physicians work together to reach these goals, these nutritional goals of patients. Of course, we also have 5 to 10% of patients where these goals cannot be reached, and for these patients we need to go into enteral or parenteral nutrition, but for the general medical ward patient, this really is a minority. So what you can see on the slide also is that here we did not have the ICD-11 code, we did not have the GLIM criteria by that time. So we did screening and we treated a very broad population, patients at risk. And I will show you how now the introduction of the GLIM criteria would actually further alter this population, and it would also improve the selection of patients that would receive then nutritional care. So patients were treated in the trial, and of course the question was, well, how effective was that in regard to clinical outcomes of patients? And so our main question was really, do we see a difference in the risk that patient would have a serious medical complication and in the risk that the patient would not survive a 30-day after entering the hospital stay. So 30-day mortality and serious complications were the main endpoints. And you can see we found in the trial, and here the blue line is the control group that did not receive nutritional care, and the red line is the patients that did receive nutritional care. And we found that for both of these outcomes, we had statistically significant improvements in regards to risk of mortality and of complications. Now, significant improvements is not very easy to communicate to patients. What is better is a number. And here the number needed to treat is a very good number because it tells us how many patients do we actually need to see, to screen, to treat, to prevent one of these complications and to prevent one death in the hospital. So in my department, we have per day, we have about 20 to 30 patients entering every day the hospital. So per week we treat, I would say about 100 patients, 50 to 100 patients with malnutrition. Now, when you look at these number needed to treat, I can say in my department, if I have effective medical care for nutrition, I can prevent 5 severe complications, and at least I can save 2 patients' lives within 30 days. And I think that's a very important number to remember about the effectiveness of nutritional care when we use nutrition in these patients. And also it's an important number because we can put it into perspective. I mentioned when I started my presentation, where do I want to spend my dollar? Do I want to spend it for cancer care, for hypertension care, or for nutrition care? So we can also compare nutrition care effectiveness to other treatments. Now, I have never heard anyone not providing a statin therapy to a patient with a myocardial infarction. Nobody would doubt this. The same is true for ramipril. This is an ACE inhibitor. Any patient with hypertension would receive an ACE inhibitor. And the same is true for the new guy on the block, the SGLT2. So that's the new drug for diabetes and patients with kidney failure. And when you see the number needed to treat for these superdrugs, it's the same league that we have for nutrition. And this is also why I think we should not talk about nutritional support. Nutrition is a therapy as effective as these medical drugs, where we have no doubt that they need to be given to our patients every day. So I think that's very important to remember. Now, in addition to these hard endpoints, complications, mortality, in the trial we also did look at other outcomes, functionality, quality of life, and we did find important improvements. And of course, you can imagine that if the functionality of your patients is improved, this also has cost implications along the way, not directly to the hospital, but to the patient, to the family, to the society, of course. No side effects in nutritional care. And so this trial was important because it showed us with numbers what actually the positive effects of nutrition care is, although we have been hearing about this for many years, and many experts around the world always advocated the importance of nutrition care, but I think it's important to put this into numbers. Now, today we have very good evidence, not only in the medical field, so this is a meta-analysis looking at different trials in the medical inpatient setting, and you can see there is trials from all around the world, smaller trials, bigger trials, some differences in inclusion criteria and so on. But you can see that overall, we see about a 25% reduction in the risk of mortality for patients being treated for malnutrition. We have very similar data also for outpatients. We have also a lot of data for other patient populations today. So as I mentioned, I think a lot of the evidence we have today is not related to the new ICD-11 code, but it's to the previous assessment. And Tommy mentioned that we had some issues about heterogeneity of phenotyping patients by that time. So a lot of these trials used different types of criteria to classify the patients. However, when we now used the ICD-11 code for our patients included in the EFFORT trial, we found, and you can see those are the patients here with the red line, and patients not meeting the ICD-11 diagnosis are the patients in the blue line. So first we saw that actually when you look at patients at risk of malnutrition, those patients actually meeting the ICD-11 code have a worse prognosis regarding outcome compared to the overall population. So this means ICD-11 diagnosis really shows you a population of highly vulnerable patients with a very high risk of adverse outcomes. Now the second question is, okay, those seem to be they have a worse prognosis. However, is nutrition as effective in these patients? And so we also compared the effect of our treatment in those patients meeting ICD-11 diagnosis to patients not meeting, and we actually found that for those patients, the intervention is more effective. So ICD-11 really shows us the most vulnerable patients and patients where we know nutrition really works. And you can see here the odds ratio is 0.69, so it's a 30% reduction in mortality for these patients. So this is about efficacy of treatment, but how about the costs? And of course, as I said, this is a very difficult discussion. It has different layers. And today, there has been a lot of papers, also models, looking into the effects of costs and effects in these patients. And there is different ways we can look at this. So one way would be we take these studies, we take the risks that we see out of these studies, and we pull it into statistical models, such as the Markov model you can see here. And so for every patient going through this model, these patients are having risks for complications. We have risks that are declining if they are treated. And then we also can put a number of costs to all the different outcomes in these patients. Now, what we found when doing such analyses is a result such as this. So you can see you have on the one hand, you have costs, and on the other hand, you have quality of life, QALYs. So what you can see here, of course, this is not a very exact metric here, but you have a cloud here. And what you can see when you look at the graph, that there is a cost to nutrition. Some patients you can actually save costs. So those are the patients where you prevent a complication. In other patients, you may not have a prevention of complication, but there is a cost. But the cost overall is zero or low or slightly below zero. So basically, the cost to nutrition is basically around the zero margin. But what is for sure in all these analyses is the quality of treatment improves. So basically what we find is an improvement of treatment and a very low cost or even cost savings associated with treatment. We did also other types of cost analysis. Let's say for the effort patient, you can look at a different angle. You can say, okay, what is the cost to prevent one death? What is the cost to prevent one complication? And so you can do a very easy scenario. So this was calculated for our patients. So they are in the hospital for about 10 days. You have dietitian time. Do you have some product costs associated with it? So per patient in our hospital, we calculated about 250 euros. And then we have the cost to prevent one complication. You can, of course, just use your number needed to treat of 25, and you come to about 6,000 euros or of about 12,000 euros then per prevention of complication or prevention of death. Now, I want to ask you, for the prevention of one death, if you look at cancer treatments, you know what types of money we're spending there to prevent one death? So this is 100,000, 500,000, a million we're talking about. So I think these numbers just illustrate that nutrition is, in regard to its effectiveness, it really has a very low cost associated with it. So I think overall, in my personal opinion, I think the ICD-11 really will help us now to to speak the same language across hospitals, but also across countries, if we have the same diagnostic code. Today we do know that nutrition is highly effective, And we also know that the cost effectiveness is very good for this treatment. And so I hope now that we can really use this data to put it into action and to communicate this also. And I think somebody said before that we are in the bubble here talking about it, but I think also it's very important to go outside the bubble and to speak about costs and effects so people understand the importance of this issue. Thank you very much.
Thank you very much, Philip. I wonder, can we get Claire online again? Hopefully we can. Okay, so, but while we're waiting for that, I'll start with the patient, okay? Now, one thing that I was wondering about was that now that there is a diagnosis, somebody comes to the patient and says, you are undernutrition. How would that actually impact the patient? Will it make them, will that drive them to really force themselves to eat more, eat better, to get the nutrition going? Or is that just something like a hammer in the head and on top of the disease? What would be the sort of the psychological reaction to it?
I think, thanks for the question. I think it would help the patient because they know that something's wrong. They know that they're getting weaker and something must be off, but they don't know why, and they think it's the disease, maybe it's the cancer or it's the whatever disease they have. So my feeling is it would help them, and it's something you can do something against. Yeah. So if they get the right coding and if they get the right treatment, then afterwards that would be helpful, I guess. Yeah, definitely.
So all helpful. Okay.
Yeah.
I think you're absolutely right. Now, the other thing, which is also a little bit on with the wording here, and you had to change from what we usually talk about, Tommy, is malnutrition to the WHO wanted undernutrition. How are we going to go about dealing with that? Because that's, I mean, there's a community that talks about malnutrition, and undernutrition actually be more specific, I guess.
Well, there was actually a ballot in Espen like 10 years ago about should we use undernutrition or should we use malnutrition? And it came out 53 for one and 47 for the others. So I think the community is divided. I still think that's a question you often get. Important, of course. I think that we in the community should not decide that from 1st of January 2028 we don't use malnutrition. I think that the coding and the concept of undernutrition in the code will drive our language into that direction. So that's at least my current position is to, of course, support and facilitate the use of undernutrition. There are, of course, a lot of you perhaps are very strong proponents for malnutrition. There are others for undernutrition, but I think time will tell.
Then I have to bounce that question to Karen as well. Will it be more precise and helpful for the patient to know that it's undernutrition rather than malnutrition?
I was just thinking, I don't know. I don't really know because for me it implies it's a little bit different. Undernutrition might mean they're not eating enough, so they might just eat more, but maybe eat the wrong things. And malnutrition is, for me, it's a little bit more precise because it says you eat the wrong stuff, not the right things. So you have enough nutrients maybe, but something's missing. So, not sure.
Okay,
quite sure.
Hard one. Well, I noticed we also are joined by Robert Jacob from the WHO. Welcome. And so I'll hand over a question to both of you. You can choose who wants to answer. When this proposal came along, was there any doubt ever within the organization that this would be something to take on? I mean, WHO is an organization that has seen a lot of undernutrition in the world.
I think when the proposal was presented, there was no doubt that this is a relevant proposal. And yes, we had the same discussions that you were having there, how to handle the terminological clarity, because maybe in English it's understood in one way. If it's translated in some 40 other languages, the understanding may shift a little bit. That's why it's so important to also have definitions there that's clear what is meant independently of the individual interpretation. And yes, the proposal was considered to be relevant, and of course it has taken time because besides being scientifically sound, we also needed to assess the impact on the data collections. And whereas, let's say in Europe, the countries are not as fast with adoption, in other parts of the world they are. So that's why it's so relevant to do these assessments. And that also means that some updates like this, that is a relevant update, that is also a change in the coding scheme, additional coding scheme, we do only at certain time intervals to make sure it can be implemented globally and to make sure that at least those who have collected some data on something will have some time series before we change conceptualization. So I hope this answers your question, but feel free, any question you may have, and Claire, feel free to add something from the European perspective, of course. Thank you.
Okay, well, we have plenty of time for discussion, so I'm just leading off here a little bit, and then I'm going to release it to the audience as well. Now, I'm thinking, Philip, now you're running a big department. You can see that this is extremely cost effective. How much money have you saved?
Yeah, well, I think I would first, I think what is important is that we first have to invest into nutritional care, right? Because we have to invest that the hospital is actually having a screening program, that actually we have dietitians that do the assessments, that take care of the patients. And then, if we provide better care, we have less complications, patients have better status, and some of the savings are also along the road when they go home. So I think from the hospital perspective, so for me, it's okay to say, if all the money I spend for nutritional care is, being reverted just by having lower complications and so on, and I go out with a zero, right? That's okay for me. I don't need to save a lot of money by that. But I know in the long run, we're saving a lot for the patients, for the families, for the community, and so on. But it's not so easy to put it into a number, right? But I think it's important not to say, okay, we're going to save here, but first we have to invest. I think that's very important as a message also.
And that's where the problems arise, isn't it? Where if you want to invest, you need more money from somewhere to do that. So how did you manage that? Yeah. Did you go to the top, the C-level, or how did you do it inside your own department?
Well, I think it's when you have your budget discussions, of course, then that's the point where you have to make your argumentation. And, as the head of the department, I can say, I want to invest, in a new robot for surgery, right? Because then I'm going to get more money by patients pay for it. Or I can invest in nutritional care and I can have, better hospital stays. So it is a discussion that needs to take place. And it's not an easy discussion. But I think more and more the data we have are more and more showing that actually it's I would say, a no-brainer, just in regards to the quality, in regards to the overall treatment of patients. But I think it needs the discussions with the C-levels, because a lot of the C-levels do not have the knowledge, about this topic.
Yeah. No, I think that's a key thing when it comes to implementation, is that somebody has to be convinced, and that somebody may not know what the situation is like. I think your data is extremely strong, actually. It's very difficult to not see it as a no-brainer. So if we just move into implementation a little bit, and I'll turn to our friends at the World Health Organization again. What opportunities do you see that we should be using, and how can you help us to to really use this ICD-11 across Europe to different member states to implement it in an appropriate way? It's a big question, and I'll ask the others to follow up on that, but I'd like to start with you. Claire, do you want to start?
Please go ahead, Robert. Thank you.
Oh, you didn't hear me? Okay, so the question I asked was, how can you help us get this moving across? How can you help us with the implementation of the new ICD-11 across Europe? Which role do you want to play?
There are different ways of doing this. Number one, we're certainly happy to use our usual social media channels in our specialized audiences to inform that this is there and it will be available officially starting from the 1st January, 15 January of 27. The other is certainly we could, for example, consider to do a global webinar like we did with other groups, like for rare diseases or for the dermatologists and others, to illustrate what ICD does in general in the nutritional area and what in particular this proposal is adding to that. And I think what I learned today was very interesting. And I think sharing this with a more global community in the context of classification and classification implementation, and like you had there, also having civil society present and presenting it from their side, I think will be something very helpful, and we'd be delighted to organize this with you.
Yeah, because I think we've been talking in the morning here about, you know, the problem that we have. We have all the data we need, and you heard a beautiful presentation also about, you know, the financial side of things, which should be extremely interesting for most hospitals across Europe, I would say, because we're all short on money. And we've heard the patient's voice, so clearly we're doing something really good, something very important. And you have a very strong voice. How much of the information that has been displayed, or that kind of information that has been displayed, would you feel comfortable with bringing along when presenting this from your standpoint, understanding that you have a very specific role in the world of health?
Well, I think that we should discuss in detail how we do this better, because we need to think if you do a global webinar, we will have a mixture of different audiences. So not only you as the scientific experts, but really total heterogeneous public.
Exactly.
So let's discuss this in detail.
Yeah. No, I didn't expect you to give the full answer, but really, I think that this is one of the things that that's a box we need to tick, and to figure out who's going to do what and how can we come across the best way. Tommy, any views on implementation? What do you think we should be doing?
I think we already have quite a few tools for implementation, of course, that we should use and should perhaps focus on the Malnutrition Awareness Week, and of course, as Robert said, to use webinars. I think we have a lot of tools, and I think that we should use them more focused, especially perhaps in the beginning of 2027. But it's interesting that you say that you expect it to be updated and be part of the external ICD-11 early 2027. And I would like to ask Robert, do you have any perception of when most people will implement the ICD-11? Because before they have implemented ICD-11, perhaps it's a no question. Would it be like 2028 for most countries, or because we still have countries that use ICD-9?
ICD-9-CM probably, so the American modification, I suppose. But the main point there is it really depends on the countries. The first countries in using ICD-11 at national level did so, adopted in really start working with it in 2022. And we will have some big countries internationally that are same level as Europe that will do this in 27. Many other countries are on the way. We have already 6 countries that are reporting standard national data to WHO coded with ICD-11. And in total, we have some 135 countries that are different levels. Europe is a little bit behind, I think, because the information systems are complex. And I think the need to coordinate across European countries is also an important factor there. But as my colleague Claire said earlier, it doesn't mean that the conceptualization cannot be used as a reference in clinical practice, whereas eventually the national coding systems are still doing the old structure. Of course, cross-coding may be losing some information, but the most important, as Claire said, is the impact for the patients and the notion that the conceptualization has changed. Thank you.
Okay. I think I'll open up for anybody who has a question to anybody on the panel. Joost has a microphone, and yeah, so we're. Oh, okay. Elisabeth Rotenberg from Sweden. She's the partner of Tommy in driving this ICD-11 thing. So, please.
Thanks for a very interesting discussion. I'm just a little bit curious. So this question is for Claire and for Jacob. You touched upon the issue, some minutes ago. How important does WHO think it is that clinicians use the term undernutrition in their daily life? I heard that Claire used the term malnutrition all the time in her presentation. And that made me, yes, a little bit confused maybe, but also curious how WHO looks upon the terminology.
Did you hear the question? So the question was, yeah.
In a very precise way to be as much aligned as possible with the clinical language, otherwise nobody will understand, at least not the ones that are making the diagnosis. And we have a whole nutritional team here in WHO headquarters with, of course, linked also to the different regional offices, including Europe. And we are taking this clarification of the nomenclature very serious. The challenge is exactly what I think you reported also earlier in the presentations, that it seems there is a split in the community on who prefers what. So our main point is to clarify the language in the ICD and put the definitions so that those that are of different opinion can still find the right category when it comes there. But undernutrition is definitely a clarification compared to malnutrition. Thank you.
Okay, anybody else? Okay, did we have a question over here? Yeah.
So thank you for your good presentations. I have a question beyond. So we know that patient stays in hospital less time, so approximately is 3 to 4 days. So how will we follow up? Because I think this is important.
Maybe I can answer your question. I think it's a very, very relevant question. And a lot of research has actually focused on what happens in the hospital. But I agree, a chronic condition should also have a chronic treatment. So this is something also we learned from our trial when nutrition was stopped later on, that the positive effects we found, they kind of diminish over time. So, and there is new research also looking at the outpatients. And again, there is also the question of reimbursement, who's paying for it, who's paying for dietitian time and products. I think that's very important.
Yeah, now we're moving into the nitty-gritty here. It's about reimbursement. So let me start with the patient's view. How many patients can afford to buy oral nutritional supplements on their own?
Well, not that many, I would say, because when you have a disease, most times you cannot work, and that makes it worse. You don't earn money, you don't have that much money anymore, and we see that as a huge problem. If they get it reimbursed, then they take it, and if they don't, they just don't take it, and they don't have the data. They don't know how important it is. So it's even more that they say, "Oh, that's not needed, so we don't, need to pay for that."
Next question goes to you, Philip. How much reimbursement would you need to make it worthwhile?
Yeah, I think that's a good question. You know, for me, it's, I don't understand why, a patient for hypertension is seeing the GP every 3 months to measure blood pressure and adapt the treatments, but for malnutrition, you don't have, money to put on that. So, of course, nutrition means, adapting your daily food intake. So that's also what you eat in your own kitchen. But then for some patients, it's important to have oral supplements if there is a gap between what you should eat and what you can eat, right? And so, and there is a cost to that. But as I said before, I think it's the dollar is a very good spend for this intervention when compared to many other interventions where we spend the dollar.
I think that's absolutely clear. Yes, please, Martin Helbeis.
So, Dr. Ferrand, Dr. Jakob, first of all, thank you very much for making time for us. Based on your vast experience that you have in this field, what would be your advice for medical societies, for patient organization to accelerate the ICD-11 implementation in countries, in member states to which they signed up to, specifically nutrition? As we have heard, it would make a big impact for patients, for treatment of malnutrition, but also for the healthcare costs. Thank you very much for sharing your thoughts.
So from my side, you will have the answer I give to all the scientific societies, that the implementation is driven by consensus, by political necessities, and in the end is a decision of the country itself. And certainly the level of interest that is shown by scientific societies and patients may be an incentive for the relevant decision makers to move the agenda forward as appropriate for that country. Thank you. I don't know, Claire, if you want to add something European specific.
Okay, question from Claude Pichard in the back.
Well, I suppose most of us can agree that the healthcare system is basically based on quality of care and cost of care. So I'm just wondering if we have for years now developed process to improve the quality of care, and I would say that in many domains it has been possible to be successful. I'm wondering why we don't have a way to do incentives to promote cost containment by improving the way we spend the money. And nutrition is a good domain to test that. As Philip Schütz said it, I mean, if you invest a little bit of money, you can get a good return of investment. So why don't we try to imagine a system whereby institution and any kind of system to care of the patient would actually be pushed toward a system where they get the benefit in case they do proper nutrition.
Yeah, who wants to pick up that ball? I think it's a good idea. I think we are one of the problems is obviously that there are different players who are paying at different levels. And you mentioned that during your presentation that you pay for some of the care and make some savings in the hospital, and then there are other savings when the patient goes home if they don't have complications, etc. And this is something we showed again with surgical patients. It was a return on the investment of about 4 point something in the hospital, But if you also started to calculate the number of ER visits, outpatient visits to the GP and all this other stuff that happens after the patient leaves the hospital, then you go up to about ×9 or ×7 or something like that. So that's another cost saving that we don't really calculate. I don't know if you've been into that in any way.
Well, I think, Claude, that's it's a very good idea, and I think the idea of having outcome-based reimbursement is very important, because in the end, if let's say you have a patient with cancer and you have an excellent cancer therapy, but then the patient dies because his nutritional status gets worse, right? We don't win with this patient. And so I see really nutrition as part of a treatment bundle, and in the end, the question is, what should be part of the bundle to get the best results, and we should pay for the result in the end. But of course, it is a change in today's way we finance the system. But I agree, it would be very important and would go in the right direction.
I think this discussion is extremely important also for our planning for the 2027, because we know that undernutrition is heavily underreported, and if the visibility and awareness increases, of course, there will be more numbers of diagnoses, and the funders will see that this is going to be more costly. Of course, we agree with Philip to say we have to spend money on this. We have to invest. But I think that perhaps we should try to come up with the good answers that we can, because I think that will be some kind of a reaction from many hospital managers. Well, we cannot afford this. This is really possible that 35% of our patients are undernourished and we have to pay like this for that. As we understand, it's really cost effective to do that. But we need to convince them, and we need to kind of train for that communication and for that discussion.
Yeah, I think so too. I was just wondering whether the WHO have any experience on the financial sides of bringing in new ICD coding, and especially these add-on codes like undernutrition would be. Any suggestions or experiences from your end, or who to talk to? Because I think that could be very helpful.
So we have a whole department that works on nutrition, overnutrition, undernutrition, malnutrition, and one can certainly work with the colleagues there in more depth where it comes to these perspectives. The other thing is, like several of you were saying earlier, the financial aspect is certainly one that makes people listen very carefully, in particular in time where resources become scarce, or in places where resources are by nature more limited than in others. And improving health with less need of resources is certainly something that is very impactful and that should definitely be heard. Thank you.
Okay, any other questions from the audience? Yes, please.
Hi, I would like to ask a question in terms of, to this panel of experts. Have you considered penalties financial, like if a hospital is not using screening tools, basically they're ignoring a diagnosis, why not impose a penalty on them? You mentioned 4.something% of savings to the hospital, why not double that minus?
We'll have a verdict from the jury up here.
Let's say you have a patient and he goes home, he has a complication because nutrition wasn't managed properly, and he takes a lawyer and goes back to the hospital and tells them, you didn't see this disease, you didn't treat it correctly, right? Then the hospital has a problem and has probably to pay for the patient. So, I think this argumentation needs just to be more, that's one of the issues, that kind of the C-level in the hospitals don't understand the importance and don't understand also the implications. And maybe we need to translate this, but from my point of view, it's a very clear case that there should be a penalty if you miss this diagnosis and if you don't treat it correctly.
I think there are some experiences from that in the way that some systems have changed so that if you have readmitting patients, that has an extra cost within a certain time period. And the effect of that has usually been that they just keep the patients in for a few more extra days. So it's not an easy system to build, I guess. Yeah, but it's a good thought.
Well, I can foresee that scenario, actually, that when it becomes so clear that the figures that Philip shows are true, which we, of course, believe in, why shouldn't that scenario come up when misconduct, well, mistreatment will cause extra costs?
Okay, well, I think our time is running up, actually. I think it's been a very... Oh, we have one more question in the back. No, we need the microphone there. We have people listening all over the world.
Hi, sorry. Yes, I'm not a nutritional expert. I have only experience with patients, and I wanted to say we also have to consider the family caregivers when it comes to nutrition, I think. Because the patients are often visited by them and they bring food. So it is a wonderful program, a nutrition program, but then we have to consider where else to get the patients food from, even when they're in hospital. I think that's important, especially when we come to different ethnic groups, for example. Then we have to consider that as well. Thank you.
Do you want
Yes, thanks for the question. I think that's a very important point. And I think that's what we said before. We need to think about how we can implement that, especially in the outpatient patients that are not in the clinic. I mean, it's a lot about education, and it's a lot about caretakers getting on the train also, and bringing them in and educating them as well, and creating awareness everywhere. I think that's a very important point we shouldn't forget. Yeah, thank you.
So I just want to say, I think this whole ICD-11 change now, I think it is also a huge opportunity in regards to how to communicate nutrition, undernutrition to the world, right? And I think this has been one of the big issues in the past. People don't know about it, they don't understand it, they don't know that we have actually treatments for it. And I think we should take this opportunity now to really bring the right message across. And I think by doing that, we can do much benefit in the world.
Absolutely. I couldn't agree more. And that's, in fact, what we are planning to do, because we feel that we have a very good stakeholder community within ENA. We have a lot of good people who knows a lot of things. So we are going to form a small group that will be like just initiate the whole program, and then I'm sure many of you, if not all, are going to be involved one way or another. So we're going to push this heavily. Okay, with that, I think I'm going to close this session. I'd like to thank the speakers and also our friends from the WHO for joining in, and I'd also like to thank and say goodbye to our viewers.